of Cardiovascular, Metabolic, and Aging Research Symposium 2023, Day 2. How are all of you today? I hope every single participant is having a splendid day. Today, we will have a series of symposiums, each with wonderful speakers, bringing you interesting and insightful materials. However, let me introduce myself again. My name is Natasha Salma, and I will be your master of ceremony for today's event. Now, allow me to present to you our first session for today, which is a keynote lecture titled Future Perspective on Translational Research in Metabolic Disorder, Cardiovascular, and Aging in Indonesia, Ethics, Opportunities, and Challenges. This keynote lecture will be moderated by Professor Badriul Hagar. Beforehand, let me introduce Professor Badriul Hagar by reading his CV. Professor Badriul Hagar is the director of Indonesia Medical and Education Research Institute. He conducted his degree for medical doctor in University of Indonesia, pediatrician in University of Indonesia, as a pediatrician consultant also in University of Indonesia, and his PhD in Belgium University. He is now currently a professor at Department of Pediatrics, Faculty of Medicine, University of Indonesia, and editor in Indonesian of journal Gastroenterology, Hepatology, and Digestive Endoscopy in Pediatrica Indonesia. Without further ado, let me introduce to you to Professor Badriul Hagar. To Professor Badriul Hagar, the floor is yours.
Okay, thank you very much. Good afternoon, Prof. Dante. Thank you very much also for your time for being with us this afternoon. Okay, I will start for the keynote lecture session this afternoon, day 2 of the first CMARS 2023. Okay, I will first to read the curriculum vitae of Prof. Dante. Please, I'm sure we all know Prof. Dante very well. He is one of the prominent experts in Indonesia in the area of endocrine, metabolism, and also diabetics. And he currently also acts as the Deputy Minister of Health, the Republic of Indonesia. Dr. Dante is very active, not only in the scientific field, with many publications, and also in various professional organisms. Okay, I think the time for you, Prof. Dante, please.
Thank you, Prof. Hagar. Thank you, and good afternoon, everybody, for this opportunity to share you about the future perspective on translational research in metabolic disorder, cardiovascular, and aging in Indonesia, opportunity and challenge. Let me to share you about this this perspective that I would like to talk to you today. Could you see my slide?
Yes, clear, Prof. Dante. Maybe you have to make short slow, please.
Yes. Then I would like to talk to you about the background transnational research in what we already done and future perspective transnational research, opportunity, challenge, and then we will conclude about this event. Ladies and gentlemen, the cardiovascular and metabolic disorders and disease is still leading global and national burden of health. The global burden cardiovascular disease.
Excuse me, Prof. Dante, maybe you have to make slideshow or full screen. This is not yet.
Oh, not yet?
Yes, not.
Okay. Not yet, yeah.
Because we see also the list of the slide in the left side.
Okay. Just a few minutes. I will to share here the slide.
Yes.
Could you see the
Yeah,
slide?
correct. Perfect. Please, Prof. Dante.
Okay. I would like to talk to you about these models in cardiovascular, metabolic disease, and disorder that the leading global national burden of health. You know, about 18 million people dead in 2019 survey in Indonesia because of cardiovascular disease. It's looked like about 30% in global death, and also 80% of cardiovascular disease death due to stroke and heart attack, and double prevalent from 19 1990 ranks to the 2019 rank. We still have a number of death that caused by cardiovascular disease still leading the number of death in Indonesia. And then in diabetes mellitus, more prevalence metabolic disease increases in the trends. And regarding the International Diabetes Federations, is about 30 million people with diabetes in Indonesia will be predict at 2045. Now we have about 20 million people with diabetes. And Indonesia is still the 5th most prevalent country with diabetes mellitus. And also in regarding the basic national health survey or RICAS in 2018, the prevalence of diabetes, we have 8.5% in our population. Increasing the trend of people with impaired glucose tolerance to become diabetes is still high in Indonesia. And regarding the Diabcare Asia model, we almost 30% of diabetic patients did not meet the optimal glycemic control. I will tell you about the glycemic control for patients with diabetes. Actually, the control of diabetes in Indonesia just only meet 30.8%. Just have A1C level, the criteria for controlling diabetes people. So it means that more than 70% of patients doesn't meet of glycemic control. The trend of 70%, it means that 70% of people with diabetes can be easier to some prevalence of complication. The most prominence of prevalence of complication in diabetic patient is because of cardiovascular disease, and the case is meet almost quarters% of patient with diabetes mellitus. Then aging population, demographic trends show increasing aging in the future. You will see here in diabetes patient in 1990% we have this pattern, but now the pattern is become changes. So the people with risk of diabetes because of aging in the population will increase, and aging population come with various health challenges, among them non-community communicable disease such as of cardiovascular disease, especially with diabetes. Then the metabolic disease, aging contributed development cardiovascular disease. The aging and cardiovascular disease is non-separated entity. You will see here in the graph, these graphs, but the heart disease, coronary heart disease, hypertension, stroke, cancer, arthritis, diabetes is still high with the people with the aging population. So cardiovascular disease burden due to various metabolic risk is remind this of a cardiovascular disease. You will see here in the 10 years evaluation in our population, almost 20 years in our population, this is the risk of aging that can make people with some risk become cardiovascular disease. National health and economic burden cardiovascular disease is very high also. The health economic cost of heart disease and stroke exceeds more than 10 trillion rupiah per year. So it means that this catastrophic should be handled. The highest mortality is still because of cardiovascular disease like stroke, cardiovascular event, and also kidney failure in people with the aging process. Then I would like to talk to you that this important burden should be covered by the knowledge of not only bedside environment to handle it, but also we need another approach. This approach is recognized by specific clinical problems, and we call as a transactional research. By using transactional research, we try to finding a possible solution through basic science research, and we transition to clinical research through human study and integration in clinical practice and a clinical guideline. This is the pattern of transactional research that's very important in people with cardiovascular disease, with metabolic disease, especially like diabetes. So what actually transactional research? So I will want to let you know that the transactional research is to be bridging of the basic research to clinical research. In traditional, research was divided into basic research and applied only for publication. However, distinguishing between basic and clinical research prove ineffective finding a practical solution in some part. It because of in basic research, researchers perform with a practical end, and some are provided general knowledge of nature and its law, not specific in a clinical answer, and also performed by laboratory scientists just only because of publication point of view. So it should be not a chance to do to make the basic research come to the clinical, meet the clinical research. It should be patient-oriented research with a practical and epidemiology, behavioral study, and practical outcome research, health efficient research should be done. So the transactional research in regarding of the National Institute of Health in the United States mean there are two areas. The first area is being processed, the applying discovery during research in laboratory. We call it a preclinical study. And the second one is the being research aimed at enhancing adoption of best practice. Regarding of that, the interdisciplinary branch of biomedicine supported by three pillars: bench, bedside, and community. In summary, I would like to talk to you the transactional research aim to provide improvement in the disease management with effective collaboration between basic research, clinical research, community, patient, and parties involved. So the actually transactional research states we have three phases. The phase 1 is the preclinical state, phase 2 is a clinical state, phase 3 is the data dissemination, and phase 4 is a transactional state. From bench to bedside, the transactional research starts with identifying the clinical problem, finding solutions starting from laboratory work, and with outcome of clinical solution. So it should be transactional research is team-based research approach with participants from various fields should be demonstrated they're unuseful, disseminated the finding, and develop the approach, and should be have collaboration between public health, basic research, preclinical research, clinical research, and clinical implementation. So the aim bridge of the gap between basic researcher and clinician to public health sector is very important to emphasize. So we will have from bench, from laboratory to the bench will be increased. So I will show you some example of transactional research in cardiovascular and metabolic aging. I will have two samples here. The first is drug development sample, and the second one is device development sample. Drug development sample in metabolics like the discovery of SGLT2 inhibitors. That SGLT2 inhibitor, it actually starts from the preclinical research in laboratory, and then from basic to clinical research, they have very beneficial, effective in cardiovascular disease in diabetes, and now widely used in clinical guideline around the world. And this SGLT2 commonly used from for the clinical doctor in the world. And another thing is from the need to providing continuous glucose monitoring. We have now the samples of glucose monitoring like this using pads, implant pads, and what they use clinical type of for type 1 and type 2 diabetes to control of glucose matters. So they can use by this technology, not should be make a pinch of blood just on the tap on the pads, and they have measuring glucose levels. So the future perspective on transnational research should be enhanced, and functions of biotechnology paves the way implementation transnational research in the faster way. So we have some interaction multi-omic approach. They are interactomic, genomic, radiomic, microbiomic, digital pathology, metabolomic, immunology, transcriptomic, and epidemiomic, and also proteomic to enhance in basic science research to be translated into clinical practice in various cardiovascular disease and metabolisms. And if we can implementing that in a clinical practice, we can use development of artificial intelligence and digital technology support massive biobank collection for research purpose and translational research to clinical practice through artificial algorithms. So translational research in that I would like to talk to you and introduce to you is not only the translational research from the basic to advanced. We now have also the precision medicines. In the precision medicines era, which aim to provide the best healthcare service specific for each patient, will be using the data from the genomic matter. The application of best scenario based on combining clinical evidence with scientific characteristic of each patient using the bands that we already have data previously, and the knowledge of a laboratory in a preclinical research that already done previously. So the development of healthcare era into precision medicine is because of in the middle of last century, we knowing about the intuitive medicines. The intuitive medicines is approach that the treatment were given based on general consensus without detailed basic science research. There are no transnational research here. They just only use the conventional general consensus among the doctors, and among the doctor in their community agree that use this basic science research to make some medication for patient. This is the middle of the century in the 18th and 19th century previously. So regarding of the increasing of our knowledge in statistical evidence, we now have evidence-based medicine. Using evidence-based medicine, basic research, translational research into clinical research were found. The translational research gave best scientific evidence base for EBM application in some patients. But now this is not enough, because in evidence-based medicine, we sometimes meet the people doesn't like as research than population sample that they use, because the homogeneity of the people with sample are not met at also not same with the people in a bands. The various combination is resolved by another approach of medicines knowledge in the future that we call as precision medicine. In the future perspective, the specific clinical translations and basic clinical combined specific characteristic translate into specific clinical scenario using genomic pattern will be made from evidence-based medicine we transfer to our precision medicine in the future, near future. In the precision medicine delivery healthcare service based on specific characteristic patient for population to classify patient into detailed subpopulation with specific management, and the translational research provide essential genomic research data and research clinical characteristic variable to be applied in precision medicine. So the big data analysis that already covers and already saved as bioinformatic will be transferred using artificial intelligence algorithms, and then combining by artificial intelligence algorithm will be see the pattern of clinical physiology, omic pattern, environment, and digital tracker like smartphone and stopwatch that I will show you later in the sample as a sample. This is detailed sub-classification into subgroup based of science. Previously, we have in using evidence-based clinical data, type 2 diabetes will have some subtypes, and that some subtypes using the same medication. Sometimes we just not meet glucose lowering effect that we will want to approach. I will already show you only 30% the people with meet the A1C level in the nice control, but more than 70% of patients doesn't have a control of blood glucose. By using precision medicine application through individualized therapy response evaluation using genomic, we try to make a specific drug is appropriate with specific people that have the specific genomic pattern. So it will be make some gathered response of the people, and we will make the blood glucose or monitoring more properly controlled and doesn't have a side effect of medication that we use. Just compare with if we just only using the evidence-based evaluation models. The opportunity challenge in Indonesia is very high because we have more efficient, affordable sequencing, increasing potential translation research, development most important and multifactorial disease like cardiovascular and diabetes. Actually, the Human Genome Project is already started since 2003, and at the time, the first genome examination transfers is caused by $2.7 billion estimate in 10 years. But now using this machine, because of minion production by Oxford University, that the sequencing of a human genome is only cost less than $200. So it is a leapfrog of phenomenon to using genomic characteristic of people if you want to using the precision medicine in our treatment. So President Barack Obama actually already initiated the first precision medicine in 2015 with the program of All of Us, which recruited 1 million subjects for genomic, clinical, and other relevant data in United States. Actually, in diabetic patient, the initiative of American Diabetes Association already start to using precision medicine in diabetic mellitus treatment. It would be finished in 2025. And genomic Thailand initiative like genomic factor of examination, variety of cancer, and Thailand population already done. And also the precision medicine in Asia, like Premier of the sample of lung cancer genomic database already done in some part. So it is important of an advancement of biotechnology lead or more affordable biotechnology device among them genome examination of the patient, which we call as precision medicines. So we should have the platform of scientific of informatic management. Now we try to make in our Minister of Health with the platform of Satu Sehat. The platform of Satu Sehat is the citizen health application. Then the people will have specific number evaluation, identification number. And if they go to the hospital, the doctor will entering the data from the medical record to their devices like their handphone. And then if they move to another hospital, the doctor can open the data what actually diagnosis they already make previously, and what actually the data of the physical examination, laboratory, and drug, of course. We will composite this evaluation of informatic data to more than 10,000 primary healthcare, more than 11,000 health clinical, more than 3,000 of hospital, more than 5,000 of private clinic, more than 1,400 laboratory, and 3,000, 30,000 of pharmacies to one application that we call of Satu Sehat. So Satu Sehat will make as a laboratory laboratory of informatic data that could be used of the central data in every patient with the healthcare application in one single numbers. So this is the Satu data that I will introduce to you. In the pandemic, we using this data actually we call as Peduli Lindungi platform. The Peduli Lindungi is already downloaded by more than 100 million population of Indonesia that is have a chance to become transferred to another application because of our pandemics is already finished in the near futures. So by using this application, the data integration through biobank electronic healthcare record by informatic coupled with collaboration of clinical researchers and university provide faster and more specific translational research in cardiovascular and metabolic disease, especially to be applied in a clinical setting and disseminated by health policy markers. So challenge in the future application of translational research of cardiovascular disease and diabetes is very specific. However, from continuously potential drug research, only a few minutes to be brought from bench to bedside with provide cost and time ineffectiveness. It because of some predictive efficacy in animal model sometimes have low result when translated to in clinical research. Another problem is because a lack of biomarker to predict a human clinical response, and also because of various factors not predicted in preclinical study and still limited small molecule targeting research option that we have. To be considering that in a clinical pattern, it's better to preliminary molecular study to examine through omic development in our laboratorium and artificial intelligent learning for the best cost time and effective potential research to be continuing in the near future, and more effective research funding through interorganizational involvement will be made in the near future. So challenge in the future application of transnational research in cardiovascular and diabetes. Current research so many drug development for diabetes and cardiovascular disease like this gastric inhibitor polypeptide, SLC 19A11, enzyme kinase, and also heart failure potential new target drug therapy like noladenosons, liraglutide, and vericiguat in for another, or also another sample that we already make in diabetes field. So developing country, including Indonesia, have to prepare for the future translation research and precision medicine era because we have a huge population. We will make good data in specific individual application, and we also have many laboratoriums that can make genome sequencing in our patient. So as a conclusion for this presentation, I would like to talk to you that cardiovascular and metabolic are still global national health burden, accounting only 32% causes global health death. Most common cause of death in Indonesia, we only meet 30% of patients with well control of blood glucose. And the prevalent cardiovascular disease and diabetes are increased. Further health and economic burden without proper intervention should be happen if we are not have a flood frog to make some true investment for this disease. Translational research along precision medicine provide possible clinical solution combat a communicable disease such as cardiovascular and diabetes. Advancement and biotechnology data processing should be used effectively to increase translational research and potential in diabetes pattern and cardiovascular disease. Indonesia should actively participate in use to genomic and other biotechnology for more cost, time-effective research to be applied in the clinical scientific population guideline. This is all of my presentation. It should be, hopefully it will have advantage for you, and thank you for your attention.
Okay, thank you very much, Prof. Dante, for the presentation, which is really comprehensive and open up insight to some opportunities and challenges as well. Okay, thank you very much. So I open for the discussion. Please, if there are any question, please raise hand or some write in the chat room. Prof. Dante,
yes,
a common also question I think for you. At that moment, as you mentioned as well in your presentation, that translational research from benches to clinic, marketplace, and community, or vice versa, has become a big issue, especially when we are talking about convergent research. You have explained also in your lecture an opportunity and a challenge, although we know that it's not easy as we talk. Actually, what is the main gap as a barrier in implementing translational research in the area of metabolic disorder, cardiovascular, and also aging? Any comment on that, Prof. Dante, please?
Yes, thank you, Prof. Hagar. However, the contains potential drug research in cardiovascular diabetes and also diabetes is because when we make a reband in the laboratory set, the predictive efficacy animal model had low result when translated in clinical research are found. This is the first one. And the second one is the lack of biomarker to predict human clinical response. It's our homework from our researchers in laboratory to find it. And the other thing is various factors not predict the preclinical study and not make attention for people with working in laboratory to make a translational research make happen. And the last one is still limited small molecule targeting research option that could be made. So this main problem that the gap of translational research to become a clinical finding apply still make that some clinical some laboratory experiments are have a gap for clinical translation methods. This is my question.
Okay, thank you, Prof. Dante. It's very clear for the explanation. There's one question direct come to me regarding the aging, Prof. Dante. The rapid aging of population around the world presents an unpredicted set of challenges. Yeah, shifting disease burden, increased expenditure on health and long-term care. The challenge comes from the fact that our current institutional and social arrangements are unsuited for aging population and shifting demographics. What do you think for this issue? And what is the proposed solutions? Okay, please.
Yes, I agree with you because of aging population, the demographic trends showing increasing aging population in the futures make the pattern of disease will be changed. Previously, we have the infectional disease still common in Indonesia and make death very high. But now around the world, the population like Indonesia population become aging population come with various health challenges. Among them, non-communicable disease such as cardiovascular will be increased. So by using that, the metabolic disease aging contributed development cardiovascular disease. The disease aging cardiovascular disease are non-separate entirely, but we will meet the various physiology of altering account for increasing risk of in elderly are still high. So the people with the aging process still doesn't inhibit it to make the aging process will happen. But the most important thing is quality of life. People with quality of life in the aging population are very important. They can also, of course, they will be die in because of aging process. But the most important is they will still in the aging era, in the aging age era, but with a good quality of life. So the man's approach for the aging burden due to various metabolic risk that will happen is the quality of life. The quality.
Prof. Danto, I think we lost your sound. Prof. Danta, maybe the organizing committee can contact Prof. Danta.
Sorry, I lost my contact, so I wish I should change to another rooms because of device problem. Prof. Hager, you can still hear my voice?
Clear. Your voice is very clear, but we do not, we cannot see your face, but for the sound is clear. Okay, more closer, I think.
Yeah, more closer. Yeah, more closer. Yes.
Yeah.
Yes. Sorry. It's a problem of my device previously.
No problem. Please continue, Prof. Danta. Is there some statement left?
Yes, because the problem I maybe it lost because of the problem of device. Of course, we have the problem because of the aging process. The most important of the aging process that we should approach, and our main goal is the quality of life. Even the people have the aging process and they will die because of the aging process. The most important is quality of life. As far as in the age of aging, they still have the good quality of life. This is of our main goal to developing some treatment that maybe they need in the age of their aging.
Okay, thank you, Prof. Danta, for the explanation. I think because of time, once again, I would like to thanks for the excellent presentation, also for the inspiring discussion. We are lucky to have you in this afternoon. I hope we will meet in the other scientific meeting in the near future. Thank you, Prof. Danta. Then I have to close this session.
Thank you.
Okay, I bring back to the community, please.
Thank you very much, Prof. Dante Saksono Harbuwono and Prof. Badrul Hagar for the wonderful session. Before we continue, we will have a short break for 5 minutes. So for the participants can turn off the camera. However, we will still have another session after, so please don't leave the meeting for all participants. We will return shortly after the break. Thank you very much.
Millions around the world live with heart failure. Yet 1 out of every 2 patients will die within 5 years of diagnosis. For these patients, the risk of CV death and hospitalization for heart failure never rests and keeps them from activities that they enjoy and people they love. Forxiga is a new breakthrough medicine that will change the way patients are treated today. Forxiga can help save more than just life. It can help save the moments that matter. By transforming the standard of care with powerful efficacy to reduce the risk of CV death and hospitalization for heart failure, meaningful symptom improvement, and the seamless convenience of once daily dosing. Heart failure takes life and what makes life worth living. Now, with Forxiga, we can save life itself.
Good afternoon and welcome back, ladies and gentlemen. We hope you had a sufficient break. We will now continue with our event with a symposium titled Heart Failure in Diabetes from Pathophysiological to Therapy that is going to be led by our moderator, Dr. Diki Levenus Tahapari, and also here today as our panelist for this session is Dr. Biri Karim. Before we enjoy the session, allow me to introduce to you Dr. Diki Levenus Tahapari to all of the participants. Dr. Diki Levenus Tahapari is from the Metabolic, Vascular, and Aging Cluster, Indonesian Medical Education and Research Institute. He conducted his medical doctor education in University of Indonesia, internist specialist in University of Indonesia, and PhD in Leiden University Medical Center. Currently, he is the chairman for Metabolic, Cardiovascular, and Aging Cluster of IMERI. He is also a staff of the Division of Endocrinology, Metabolism, and Diabetes of Department of Internal Medicine, FMUI, chairman of the Indonesian Thyroid Association Jakarta branch, treasury of the Indonesian Society of Endocrinology, and head of the Pituitary Working Group, the Indonesian Society of Endocrinology. Without further ado, let me introduce you to Dr. Diki Levenus Tahapari. To Dr. Diki, the time and place is yours.
Okay, thank you very much, Natasha, for the very kind introductions. A good afternoon to all participants of the first cardiovascular metabolic. Also to say welcome to Professor Lam, as well as Dr. Mulyawan. Good morning, Professor Lam. So in this session, we will have two experts on the cardiology. The first one will present about the role of imaging, and the next one will present about the clinical applications in terms of SGLT2 inhibitor in heart failure. So we also have our panelists here, Dr. Biri Karim. Maybe I will invite Dr. Biri Karim as the panelist. He's a cardiologist working at the Dr. Cipto Mangunkusumo Hospital, and he will be joining us today as the panelist for these sessions. So without further ado, I would like to invite Professor Lam to give his lecture on diabetes imaging in association with cardiovascular complications, comparison between Western and Asian populations. So before inviting Professor Lam to give his lectures, I would like to first introduce him. Professor Lam is a professor of radiology and director of cardiovascular imaging at the Leiden University Medical Center. His clinical focus has been on cardiovascular radiology, thoracic radiology, mammography, and also periodic radiology. And he's also the chairman of management team research for the Department of Radiology LUMC. And he's also the CV of Dr. Biri Karim. He's currently the staff of Cardiology Division, Department of Internal Medicines, Dr. Cipto Mangunkusumo Hospital. So without further ado, I would like to invite Professor Lam to give his lecture. Please, Professor Lam, the time is yours.
Yeah, thank you very much for the nice introduction. So, I hope now you can see my slides.
Yeah, we can see it clearly. Thank you.
Perfectly. So yeah, it's a nice opportunity to show some of the work we do within imaging. I am a professor of radiology and a clinical radiologist, but actually I started as a biologist. So that's why I'm still interested in a little bit more basic side of radiology. And the title might be intriguing for you, diabetes imaging. What is it? Well, it is a sort of focus with imaging techniques, MRI, CT, ultrasound, other techniques, to study metabolism in the living human. And then in this lecture, I try to make a connection to cardiovascular disease, and I will show some studies we performed comparing Westerns and the Asian population. I have some disclosures as shown here. In obesity, as you might know, of course, there's a tight link to cardiovascular disease, and it can be studied in a very simple way, also by ultrasound or whatever technique, by looking at some basic functions of the heart, like volumes and ejection fraction. And in one study we did in the UK Biobank, in a large cohort of a little bit more than 4,000 people, you can see that there are distinct differences between people with high subcutaneous fat or high visceral fat volumes. And for example, here you see that in the visceral fat phenotype, you have a reduced ejection fraction already. So there is no real diabetes or any other disease. This is just the increase of the visceral fat. What is quite interesting about obesity and later on type 2 diabetes is that it's a disease, of course, of the system, of the whole body. So what I like to do is study the interactions between all the organs. And actually we did work on all these organs, but now I will only focus on the heart mainly. And show a little bit about the kidneys, but for other topics, maybe later on or next year. We developed a sort of concept why this diabetes imaging and especially fat imaging is important. And that is mainly due to the observation that we made already around 2000, a long time ago, that all the layers around the heart behave different. So we have an epicardial fat layer, pericardial fat layer, and they are called together the pericardial fat. But if you do interventions, I'll show some, they respond differently, and also in relation to visceral fat and subcutaneous fat. But also, for example, I will not show that today, but pericoronary fat is quite interesting. But I believe actually that all this is related to liver metabolism, and that the pathophysiology of, for example, atherosclerosis in the vessel wall is exactly the same everywhere else in the body. So what happens, that is the hypothesis we work on, is that you have fat accumulation, then you have an inflammatory response by the body to respond and repair and try to get rid of the fat. And that causes a fibrosis or steatohepatitis. And in the end, you have scarring, cirrhosis, and that can proceed even all the way to malignancies. So now we are having a strong focus on the liver-heart interaction to study the relation between fat in the body, visceral fat, liver fat, and later on steatosis and then organ failure. But for now, I will mainly focus on the heart, where actually the same process is going on in the myocardium. So you have fat accumulation, then an inflammatory response, and later on also a sort of scarring or fibrosis as an end stage of the disease. And this is, of course, the basic biology showing the mitochondrium. And what we are now capable of studying is a couple of aspects, like PCR with phosphorus spectroscopy. But today I will mainly focus on proton spectroscopy. So this is not imaging, but we still use the proton nucleus for determining the metabolic activity. And this was developed some time ago. You can perform it preferably 3 Tesla, but 1.5 Tesla, it's also possible to do with MRI. And what you do, it's a quite complicated technique, but in essence, you put a volume on, for example, the septum, and then you do spectroscopic measurements, and then you get a signal from the triglycerides in the heart. That is actually the biggest fat peak you see. You have some other peaks from the membranes and from creatine and some other elements, but now we are focusing on the triglycerides, and this is actually a real metabolic measurement. And why do you want to do that? Well, mainly because in the normal situation, you have here the blood pool, and then you have a fatty acid flux into the cardiomyocyte, and that is usually processed in the normal way, oxidized, used, and that's it. hopefully for all of us, that's how it works. But in diabetes, for some unknown reason, and that is quite intriguing, we don't know, there is an increased flux of these fatty acids from the blood plasma into the metabolic cycle. And this causes an overflow of the metabolic intermediates to the Krebs cycle, and the cell cannot handle that. So the energy has to be stored in the form of triglycerides, little droplets of fat. And this is actually what we measure with MR spectroscopy in the living human. And we know from animal research that in this conversion from storage to actively usable metabolites, you have intermediates, mainly ceramide is known for that, that has a sort of toxic effect and interferes with cardiac function, but also liver function and other cell function. But now we focus on the heart. So this is quite devastating in the end. So we wanted to study this. I will quickly show some older work. So what we did in healthy volunteers to start with, here you have these peaks. This is the baseline experiment. Then we did a 3-day very low calorie diet. And actually we expected when you do a diet, the fat content will decrease. But to our surprise, the fat content increased. And we repeated this in more volunteers. And we couldn't believe it actually. Then we said, okay, let's do not 3 days of low calorie diet, but 3 days of starvation. Do not eat anything, just water for 3 days. And even more to our surprise, the fat content increased further in the volunteers. So this was quite surprising. And then we thought, why is this happening? So how we interpret it now is that it's a sort of evolutionary adaptation of the cell, that when there is a shortage of energy supply, the fat deposits in the body, maybe the liver, are recruited and redirected to the main organs, like for example, of course, the heart, to save the heart. On the long term, this cannot go on. So if you have prolonged starvation, we will see later, the idea is that indeed it decreases again. But what was quite interesting here is that we also studied heart function and mainly diastolic heart function. And also there we found a relation in healthy people between the fat content and the diastolic function. So actually the diastolic function, the filling function of the left ventricle reduced a little bit in these volunteers. So it was a direct connection between the dose of the from baseline to starvation and the response in diastolic function. Then the next step was the other end of the spectrum. That was a terrible experiment. So people were drinking whipped cream for 3 days. It was quite bad, but we also had the chair of internal medicine involved and the chair of cardiology. They were the subjects also of the study. And what we expected there, of course, again, was an increase of fat in the myocardium. Well, that was also surprising because there was no increase in myocardial fat. So apparently there is a protective mechanism in the cardiomyocytes to prevent the crazy accumulation of fat. And to check if the volunteer really did the terrible experiment, we saw that indeed we had an increase or doubling of the fat content in the liver. Also in the blood plasma, we saw an increase in the fat. So this proved that they really did the intervention. So this was again quite interesting because also the heart function was unchanged in this experiment. Then we went to the next step to see, are there any effects of aging? We knew already that if you get older, the E/A ratio, for example, from ultrasound studies, that reduces. There's nothing to do about it if you get older. But now also after correction for all kinds of factors, we observed that when you get older, the E/A ratio decreases, but the myocardial fat content increases. So this is a sort of fate that we all have to face later on in life, that when you get older, you also have fat accumulation in your organs, especially in the heart in this case. Then in type 2 diabetes, we compared just the patients with the healthy subjects, no intervention. And then indeed you can see here that the myocardial fat content, the triglyceride content measured by spectroscopy in the myocardial septum is increased in these patients. Of course, also in the liver, but that was already known by spectroscopic studies. And again, we found a relation between measures of diastolic heart function, the early over-atrial filling ratio, for example, and the myocardial triglycerides, also after correcting for cholesterol levels, blood pressure, other disease, whatever. It was in an epidemiological model. So this was again confirming the observations we had in the volunteers, but now in the patients without any diet, without any overload or underload of calories. Then the question, of course, is can we reverse this? Then we subjected these patients to a very low-calorie diet for 3 months. And indeed, it was shown that we can reduce the effects. So we can reduce the myocardial fat content by just a diet of 3 months. And indeed, we can also improve cardiac function by that intervention. So this shows you the amazing effects of dieting. I still believe I will show some other interventions, but dietary intervention is actually the best you can do above all other interventions. Then we said to these patients, after the diet, go home, be happy, do whatever you want, go back to your diet or just eat normal. And we did a rescan after 18 months. And the idea was that maybe a short-term diet has a long-term effect. And that turned out actually to be true, because the diastolic function between baseline and the short-term intervention was improved. But even on the long term, it was a little bit reduced from the directly after intervention. But compared to the baseline, even after 18 months, we saw a positive effect of the diet, which is quite amazing, actually. We also studied a sort of measure of the filling pressure. That's how you can do it also with ultrasound, the E over E prime. That is the motion of the mitral valve in the longitudinal direction of the heart, as compared to the volume of the left ventricle. So this is a sort of estimation of a pressure-volume relation. And it shows actually that at the long-term 18 months follow-up, you still have a sort of normal filling pressure. And it was at baseline, you need a lot more pressure to fill the left ventricle. So again, here you see that there was a little bit sustained improvement of cardiac function in the long term without doing any diet. And actually now we just finished another study on this. We still have to publish it, but that is the concept of intermittent fasting. So what we did is that patients had to fast for 5 days every month, the first 5 days of the month. Then the rest of the months, do whatever you like, and continue that cycle for 1 year. And then we studied again all these parameters and the fat distribution and the vascular and whatever. And the first results show indeed that if you only fast for 5 days every month, that you have even bigger effects as shown here. So that is maybe a trick for people to adhere to their diet, because it's quite hard to do it, to diet all the time. So maybe better is to diet only a few days and then live like normal and then again a few days. Now then you can also say, let's look at the effects of exercise. There are some effects of exercise, but they're less profound than in diets. For example, what we see here is the 2 different layers I mentioned, the epicardial fat layer and the pericardial fat layer, and only the pericardial fat layer responded a sort of similar way as the visceral fat in the abdomen. So this shows that these layers of fat are metabolically or endocrinology like different fat pools. And also here you see the subcutaneous fat, no change at all. So this is quite intriguing, because it depends on the type of intervention, how the body responds, and also what the beneficiary effect is. This was also studied in the liver with spectroscopy, and we observed a huge decrease in liver fat and almost a little bit reduction in body weight, but that was not so profound here. So it was mainly the exercise effect itself. Also in other aspects, for example, fat in skeletal muscle, we observed no change. And also in the myocardial fat, there was no change. So this shows that, yeah, exercise, everything you do is okay, but at least for the cardiometabolic status and the fat metabolism, this does not have real big effects. It's better to do a diet or maybe combined exercise and diet. Then another extreme intervention is, of course, bariatric surgery. Here you see somewhat the same effects as exercise, but also a little bit significant decrease of the epicardial fat now. So again, this shows that these fat layers and fat pools behave differently. Of course, also you can apply medical intervention. I'll quickly show this intervention. This is the PPAR gamma trial we did, where the idea is that diabetics are mainly depending on their fatty acid metabolite chain, and we like to force them back to their glucose metabolism with the PPAR gamma. But yeah, it is there are some effects, little effects. For example, the insulin sensitivity in the study group increased a little bit. We measured that with PET-CT. And even decreased a little bit in the control group with only metformin and not the treatment drug. There was also a little bit of improvement in diastolic heart function, but this drug is now not available anymore because in severe heart failure, it was not allowed to give this drug because you get deterioration of cardiac function. In this study group, we had not that effect because these were early diabetics without cardiovascular complications. But it's not on the market anymore. So then later we started a trial with liraglutide. That's a GLP-1 analog, one of the first generations. Now you have other variants available, but this drug is still available in the clinic. We did a randomized trial in a small cohort because we were quite sensitive with our MRI measurements. And here the main finding was that the drug, the GLP-1 analog, reduced the LV filling pressure, thereby also unloading the left ventricle. So actually the preload of the heart reduced based on the drug. Also, when we looked into more detail, then the treatment group participants lost more body weight as compared to the placebo group. Also, the subcutaneous fat reduced, but not the other fat pools. So there was no change in visceral, hepatic, myocardial fat in this study. But what was more important, that maybe not the drug effects directly were important. We did a separate study on glycemic control, so just looking at the HbA1c to check for the long-term glucose loading of the blood, and that actually was quite substantially improved. So actually we think that it's not per se the effect of the liraglutide and the GLP-1 analog effect, but it's mainly the tight glycemic regulation. And that was associated with reduced fat in the liver, but it was not a special effect of liraglutide. It was just the effect of a good doctor with watchful treatment and interfering in the regular medications, like increasing the insulin or metformin or doing other things outside of the liraglutide. And now in our center, we call this the Bizino effect, because this was the guy who did the study and the effect was quite pronounced. Then we proceeded on comparing this to people from South Asian descent in a separate trial with the same setup, the same sort of numbers. So this was the same trial with effects of liraglutide. Here we observed anything you can imagine that you can measure. but there was a lot unchanged. So for example, here the diastolic function was unchanged, the ejection fraction, the volumes, the cardiac index, all these things were unchanged, and we measured that using 4D flow of the whole heart. So this was a really precise and accurate measurement, but there was no change here, at least for cardiac function. But when we looked at other parameters, like again, the fat distribution, then there were really interesting effects in the study group of the type 2 diabetes from South Asian descent. So they showed, again, a decrease in body weight. They also showed a significant reduction in visceral adipose tissue, that is shown here as compared to the placebo. Also improved glucoregulation measured by HbA1c. And yeah, of course, for the clinic, this is quite important because you have to take into account the origin and the background of the patient. So you should not treat somebody from South Asian descent in the same way with the same drugs and the same dose as people from Western descent. Later on, we directly compared both groups head to head. There were some similarities. For example, here, both of the groups showed that the diastolic function is impaired anyway at baseline. So this is before the intervention. So both of the groups showed diastolic dysfunction. But the difference was that only in the South Asian groups, we found that the left ventricular mass and the extracellular volume measured by T1 mapping MR was decreased. And only in the Europeans, in the Westerns, we found that the myocardial triglyceride content is increased. So this means actually that in the people with South Asian descent, there was no fat accumulation. Again, quite shocking and intriguing that this is so different between these groups of people. So that led to our conclusion here that you need tailored strategies. You cannot treat people the same way. So you have to go indeed, as I saw before in your slides, you have to go to personalized medicine, to high-tech, tailored, specific interventions, and not treat everybody the same. Then also we asked in the same study, what about the kidney? What can we see there? We did spectroscopy. I will not comment on all these studies because it takes too much time, but we did a very simple measurement, and that was measuring the fat inside the sinus of the kidney. So this is not in the cell, but it's only sort of visceral fat outside the kidney, but only in the sinus of the kidney. And the idea was that this might reflect also a different pool of fat as compared to intracellular fat, but also visceral fat. And this is a lot of work, so we developed an AI-based neural network to automatically quantify the kidney, the total volume, and also the fat in the sinus. And this was the result, a little bit complicated results. This still has to be published. But what we observed in general is if you are normal and you go to type 2 diabetes in general, then you have enlargement of the kidney. And then, of course, the idea is that this affects kidney function because maybe related to cell hypertrophy, to edema, and some effects that are deleterious to the kidney function. So actually the idea was if you regulate the glucose in a tight way, no matter how, but in this case we did liraglutide, that you could return the size of the kidney to the same size. And of course, also the hypothesis was that then also the visceral fat, the sinus fat in here in the pilum area also reduces. And then it got very complicated because here we observed all kinds of very unexpected, strange differences between the Westerns and the South Asians. For example, after GLP-1 analog liraglutide treatment, we observed a decrease in total kidney size in the Westerns only. Really strange. In the people from South Asian descent, we found a decrease only in the sinus fat, But in the Westerns, we even found an increase in the sinus fat after treatment with the same drug. So this is really intriguing that people are responding so differently. So this was not only, of course, here you see the differences between the two groups for all the patients. So for the whole group, we also observed a decrease in total kidney volume, but that is mainly because the Western patients were decreasing. So this is quite intriguing. So we are still setting up additional experiments to figure out, what is the meaning of this? How do we interpret this? How do we have to make a clinical conclusion and incorporate this in the real life? So if you want, you can also do animal experiments or human experiments, because this is quite intriguing what is happening here. So all these fat pools apparently have different metabolic activity and different receptors and different hormonal activity and inflammatory responses. So that is very, very intriguing for the future to figure all this out. Nobody knows this about the fat, why it is behaving like that. Well, very shortly, I will not go into all the details, but we did a lot of work on the liver. But that is a separate topic that I can talk about for a couple of hours. But I just want to show you that we are now converting from MR spectroscopy to MR imaging, because that's easier in the clinic. So we are now running a study in almost 7,000 people with all kinds of measurement, but also this liver scan. And this is based on the liver multiscan from a company in Oxford where we closely work together. And what you do here is just a simple measurement of the fat in the liver with proton density fat fraction. That's a very simple technique that everybody can do. We also do T2 star mapping to measure the iron content. And we do T1 mapping of the liver and correct the T1 for the iron content. So that's why it's called corrected T1. And this measurement is quite intriguing combined with the fat accumulation here, because this parameter can be interpreted as fibroinflammation of the liver. So here you see that in the NASH situation with steatohepatitis, you see an increased value of this corrected T1 representing inflammation and fibrosis. So we are now studying large cohorts to further interpret and establish the clinical value, how to deal with that. We already proposed a very simple, pragmatic way how to deal with these numbers in the clinic. Of course, if you have a low value, then if low risk, then you can stop. But if you have a higher value and higher liver fat percentage above about 5-6%, then you can determine what to do based on the corrected T1, on the liver inflammation and fibrosis number. So if this is still low, let's say normal, but your liver fat is increased, then you can go to the primary care, to your regular physician. But if this value is intermediate, then it's not maybe so severe, but you need some treatment and guidance, then it's better to go to internal medicine office. And if it's really high, then you have to go to hepatology, because then you are at risk of real cirrhosis and liver failure and malignancies and other severe problems. So this is just the first advice we give in a review. It's not a guideline, but it's some suggestion, and we are testing this now prospectively. Does this work? Does this really help? That is a study called the Radical study. And we are also now in the process of publishing the results from that. And also in liver transplant patients, we are doing the same technique. And the idea is that we can replace the invasive biopsy by a non-invasive MRI. So then overall, to summarize a bit, what is the diabetes imaging concept? Well, actually, we try to connect all the organs, and we are applying the same hypothesis from all the data we have that we know from atherosclerosis, because of course, atherosclerosis is studied very, very extensively. We know a lot about the processes in the vessel wall, and we propose that actually everything that happens in the vessel wall happens all other places, even in the brain. We did some studies. but also in the liver, the kidney, and the heart. So that is all the steps we are trying to do. And we are trying to connect all these organs to build a sort of whole body systemic analysis and incorporate the interactions between the organs to understand the disease progression. And hopefully later on, one of the ideas is that we measure the lipid content in the myocardium and all the parameters in the liver. And what we want to know, and that is the goal for this larger scale study in 7,000 patients, we want to predict who will be obese and happy, nothing happens, and the other group is obese and they progress to diabetes type 2. And we don't know why one patient is only obese and the other patient is obese and gets diabetes and cardiovascular complications. So if we can predict that, separate these groups, obviously we can apply more aggressive therapy to the group that we know that will progress to type 2 diabetes. And this is all the concept what we have to do with imaging, in this case MR, but it can also be with other techniques. So of course, here in the end, there's nothing you can do anymore. You have cell death and fibrosis, but for the therapy, diet, medical intervention, exercise, bariatric surgery, whatever you want to do, the goal, of course, is to revert from the inflammatory stage to only lipid accumulation, and maybe even, if possible, go back to the normal state in the same way. If you are interested in your own visceral fat, I have a nice trick, because you don't need a CT or an MRI. So if you go to this website, you can type in your age, sex, height, and weight. If you know it, also your waist and hip circumference, but it's not needed. Then you can say calculate, or calculate without waist hip circumference. And then you can calculate your own visceral fat volume without an MRI. And we showed in this paper that actually this is extremely accurate. So if you want to know the visceral fat of a patient, you don't have to do imaging. And we also did an interventional study with the intermittent fasting. And actually we could observe exactly the same effects without doing MR, just using this AI-based modeling of the visceral fat. Now we are also working on a technique to do the same for the liver fat. So that's quite terrible for a radiologist, because now we can do everything without imaging. But still, I think there is a big demand for other aspects, of course, in the disease. Just as a sideline, it's maybe funny to know that there's a podcast that I do called the Radiology News Network. So if you want to know more about meetings, conferences, or topics, I interview a lot of people. So if you are interested to be interviewed and a guest in the podcast, you're more than welcome. And one other nice thing to mention is that if you like the topic about the fat metabolism and fat accumulation, now there is a book published about all these aspects, even about things that I, of course, did not discuss. So we have a lot more therapies. We are also working, for example, on fecal transplant therapy as treatment. It's all described in the book, the pathophysiology and why it's important, but also the medical treatment and how to deal with the patients. And maybe most important, if you like to visit us in Leiden or want to collaborate, you can just send me an email. And then we can start a nice collaboration. So I thank you for your attention, and I think later on there will also be a discussion to ask questions.
Okay, thank you very much, Professor Lam, for your fantastic lecture. I know it's a bit beyond the time, but I think what you share is really interesting. I think there would be a lot of questions from the audience. There are a lot of burning questions. But before we start the Q&A sessions with the audience, first of all, I would like to invite the second lecturer first. I would like to invite Dr. Hari. He is an endocrine cardiologist from Universitas Indonesia Hospital. Dr. Hari.
Okay, thank you very much, Dr. Diki.
Time is yours. Yeah.
Can I share my screen? Okay. Okay. Can you see my screen? My slide?
Yeah.
Yes.
Yeah, I can see it clearly.
Okay, thank you very much, Dr. Diki. So, good afternoon, everyone. So, Dr. Diki, I'm actually very thankful to be invited as a speaker. I'm very excited with the lecture previously by Professor Lam. So, but today I will my talk regarding the role of dapagliflozin in heart failure patient with type 2 diabetes and non-type 2 diabetes. So it's more a clinical side way compared to the mechanistic studies that were already done by Professor Lam. So yeah, of course, this as my disclosure, this meeting is present the funding from the AstraZeneca. So as we all know, the heart failure, especially across the Asia and Indonesia, have high burdens. Although this difference in several organizations of care, as we can see, we can focus in Indonesia. The readmission rate by 30 days is around 7%, and with the means hospitalization is 5 days. In patients, 3%. You can see the cost of hospitalization is somehow we can lower cost. Actually, because the limited budget in Indonesian's national coverage insurance. And we can see the pharmacological treatment mainly in the coverage insurance is RAS inhibitor, beta blocker, and also there's diuretic, also digoxins. And the other things is like ivabradine, MRA, maybe not too many people use. You can see, although the pharmacological treatment of those we call it GDMT has shown can reduce the cardiac heart failure rehospitalization and mortality. Even in some studies already done by Paradigm Heart Failure for the sacubitril valsartan shown that it can reduce. We still have a lot of residual risk factor for these patients to undergo heart failure hospitalization and mortality. That's why there's still we need more research and more clinical studies that can improve the residual risk of heart failure patients. So I would like to use some of my case. This is a real case just to guide for this art to the talk. In this patient, there's Mr. S, 65 years old, with signs clear heart failure, yeah, with orthopnea and bilateral leg edema. And interestingly, patients have a history of type 2 diabetes for 5 years, yeah, and hypertension. And patient already done PCI 2 years prior, and at that time the echocardiography's function is still within normal limits. And see the ejection fraction is 60%. But somehow after several years, the patient now suffer from heart failure and have a reduction of ejection fraction into 35%. So one of the question, why does it happen? Because if you can see from the blood pressure and also from the blood glucose still seems controlled, the diabetes seems controlled. So why this patient still experience of heart failure, even reduction of ejection fraction, although he also already got complete revascularizations. So before we answer those questions, we'll know or diabetes increased risk for cardiovascular disease, that alone increasing two times increased risk of cardiovascular event. So what we have to do with the Mr. S, yeah. From the diabetes perspective, of course, we have to do glycemic control with these several old criteria actually, but the study shown that only intensive glycemic control is not related to cardiovascular, cannot reduce the cardiovascular event. You can see, though, from all meta-analysis shown, intensive glycemic control didn't have an effect on cardiovascular outcome. And we see even the HbA1c shown that there's a U relationship between A1c and the cardiovascular outcome. So especially something else that we have to done in a patient with type 2 diabetes. And there's several factors to consider when choosing the therapy, from the glycemic control, regimen complexity, and of course we have to see now the cardiovascular outcome. So there are several drugs, medication, I think, for anti-diabetics can show that. Today I will focus more about SGLT2 inhibitors because we found from the studies, I think the consistent effect of SGLT2 inhibitor in reducing the cardiovascular event compared to other diabetic drugs. Just overall that we know that the SGLT2 receptor antagonist SGLT2 works in the kidney. There's around more than 90% the glucose has reabsorbed in the kidney and the SGLT2, and 10% less than 10% in SGLT1. Okay, next move that the study, this is one study that first entering the importance of SGLT2 inhibitor in patient with cardiovascular event. So declared to me one of the study is a broad study showing in the patient not only established cardiovascular disease, but also in the patient with risk factor, multiple risk factor. And has been shown in the study that the declared to me showed that the dapagliflozin is non-inferior in the MACE and also reduce the heart failure hospitalization compare with the placebo. This is very striking at the time because they only want to find actually the result of the cardiovascular event in the patient with diabetes, but they also found the reduction is more profound in the patient with heart failure. So this one, they further do another study compare to show that the effect of the dapagliflozin in the patient with heart failure in the DAPA-HF study. So you can see the consistent result that the dapagliflozin can reduce the composite endpoints of cardiovascular death and heart failure hospitalization even as early as 28 days. You can see you can reduce the reduction of the heart failure hospitalization and cardiovascular death composite outcome. Although when they do the subgroup analysis, they found that the major effect is the reduction of the heart failure hospitalization as early as 28 days. I think it's very good. This is of course the studies on top of heart failure medications. And how about the component? This is also can see this in this slide. Can see the question whether the dapagliflozin only work in patient with type 2 diabetes. So strikingly, that they found that this effect consistently shown the reduction not only in the type 2 diabetes but also in the patient without type 2 diabetes. So showing that there's actually so many we didn't know about the SGLT2 inhibitor, especially in a heart failure patient. We only know the effect is good consistently whether the patient have type 2 diabetes or without type 2 diabetes. It's also consistent efficacy, and we can see once again that the sub-analysis shown that the effect is more profound in reducing the heart failure hospitalization compared to cardiovascular mortality. So those studies also shown that the SGLT2 inhibitor has a well-established safety profile. So of course, different from the other medication of heart failure, such as beta blockers, of course, sacubitril valsartan, or other vasodilator agents that shown risk of hypertension. Dapagliflozin have low risk of hypertension. Then from the study also low risk of renal function dysfunction, also no hyperkalemia, making this dapagliflozin is very easy to initiate in patient with heart failure patients. And as of course, they also did the study in the CKD patient, as shown in the DAPA-CKD in a patient with heart failure and CKD. Even they also found that the dapagliflozin can preserve renal function in the patient with heart failure with CKD. So based on those data, it's shown that there are several guidelines now that change and revise the guideline. This is we can see from the American Heart Association inserting SGLT2 inhibitor as the first class for patient with heart failure reduced ejection fraction, and also in patient with the guideline from European guideline also shown that they now inserting the SGLT2 as the first line drugs, class 1 drugs for patient with heart failure and reduced ejection fraction. So what is the proposed mechanism? Of course, as we can see previously that SGLT2 works in the kidney, but apparently it's work in a lot of condition, especially in the heart. There's several proposed mechanism of the SGLT2 inhibitors. I will not talk much about this. As we can see, there's so many things we can study with SGLT2 inhibitor, and most likely they not only work in the kidney as a diuretics, but also increasing and reducing the infecting the metabolism in the, maybe also in reducing insulin resistance, increasing endothelial functions, and also increasing bioenergetic in the heart. So back to Mr. S, in our patient, so we initiate the dapagliflozin in those patients, and also we increase the furosemide for decongestants. At the time, I stopped the glipidones, sulfonylurea, due to, at the time, I am afraid of potential hypoglycemic concern. And then after 2 weeks, the symptoms were significantly improved into NIHA functional class 1. We're able to moderate exercise, and the blood pressure is within normal limits. At the time, as expected, the fasting blood glucose still high. And so I initiate the sulfonylurea and reduce even the decongestion system furosemide into only once a day. And after 1 month, the patients report the physical activity and moderate walking exercise without any apnea. The vital signs with the normal limit, blood glucose is controlled, the creatinine function is preserved. And then I reduced even the patient after 6-month visit. The patient was very stable. I didn't put a furosemide as the cognition problem, and also the LVF improved into 66%, showing the ability of the dapagliflozin in modulating in patient with heart failure. So, and there's another case in my case for patient with without type 2 diabetes. As we can see, this one is another patient, Mr. A, 48 years old. This is without diabetes. Also, same, the patient have coronary artery disease, already complete revascularization. At the time, the ejection fraction is 65%. But upon arriving at the patient clinic, the patient have ejection fraction of 15%. So, and also the TAPSE as a right ventricular function is decreased. So what we can do, actually, the dapagliflozin already shown, the SGLT2 inhibitor already shown consistently benefit in the patient with heart failure and reducing ejection fraction without and with and without diabetes. You can see this is reduced. And so what to do at the time, actually, because the patient is in the functional class 3, I advised him to get hospital admission, but the patient refused. So I did IV furosemide for decongestion and increased the GDMT, and also insert the dapagliflozin as expected in the guidelines. And what happened now is the patient, of course, improved the functional capacity, also the vital signs with the normal limit. You can see after the 3rd visit, the patient now already work normally, and he can work normally, and also he can exercise very well. So I increased the GDMT, and of course also the same, I reduced the furosemide dose, so the patient doesn't need a complete decongestions. After 6-month therapy, patient ejection fraction was increased from 15% to 25%, and later on 38%. Of course, the right ventricular functions also increased. The patient now is within stable, so he's happy with 6-minute walk test more than 150 meters. Another one is how the role of the dapagliflozin or SGLT2 inhibitor in heart failure preserve ejection fractions. So I just want to put small data, because actually not small data. This is just new study, a liver study in the patient with mildly reduced and also the preserved ejection fraction. And they also consistently found that the SGLT2 inhibitor can reduce the heart failure hospitalization even in a patient with mildly reduced and preserved ejection fraction. So in all, SGLT2 inhibitor, whether this is the liver study from the dapagliflozin or Emperor Preserve from the empagliflozin, shown consistent benefit of decrease of cardiovascular death and vascular hospitalization. And from the meta-analysis of 5 large RCT, shown that consistently the SGLT2 inhibitor can improve heart failure hospitalization across the spectrum of ejection fractions. So not only reduce, but also in the preserved patients. So in Indonesia, the dapagliflozin approved indication for now still only for heart failure reduced ejection fraction in patients CKD, but not yet approved for preserved ejection fraction. Although I already use it actually for in the case previously I present. So as my take-home message is type 2 diabetes is associated with high cardiovascular mortality, as we know. And only targeting glucose lowering is not enough to reduce cardiovascular mortality and morbidity. In this case, I already present and shown the efficacy of dapagliflozin, demonstrating the beneficial effect of reducing cardiovascular mortality and heart failure hospitalization, despite and preserving kidney function in across heart failure spectrum, not only reduce ejection fraction, but also the preserve ejection fraction in with and or without diabetes. So that's all about my talk today. So thank you very much for your kind attention. Assalamualaikum warahmatullahi wabarakatuh. I give back to the Dr. T as moderator.
Yeah, thank you, Dr. Hari, also for the very interesting presentations. So we are lucky today we have both presenter. The first one talk about on the basic aspect and also the imaging aspect, and then Dr. Hari complete the lecture with the clinical applications as well as using about the intervention using SGLT2 inhibitor and how the response in terms also in terms of imaging as well using echocardiography. I would like to invite Dr. Biri as the panelist. Good afternoon, Dr. Biri, as well as Professor Lam and also Dr. Hari. We would like to have our discussions. So maybe for the first part, I would like to invite Dr. Biri to give his questions. Please, Dr. Biri.
Thank you, Dr. Diki, for the opportunity. First, I would like to thank and I would like to welcome Prof. Lam and also Dr. Hari for the excellent presentation, excellent lecture. I honestly learned a lot from both of you. I start my question to Prof. Lam. Prof. Lam, you mentioned earlier that the diabetes CT imaging is important things that we have to know regarding we want to connect all the organs for among diabetes patient. So basically we want to investigate, is there any chronic complication happen in our diabetic patient? But usually to connect all organ or to detect is there any chronic complication, we use the simple way that the most easier to do. Let's say we do the carotid Doppler to rule out is there any plaque of atherosclerotic plaque on the carotid vessel. We do CT for the coronary or to measure the calcium score. We do the ultrasound to detect is there any intima thickness and other organ, let's say the proteinuria through the urine examination. But you mentioned what you do to connect all the organ. Sorry, correct me if I'm wrong. You use MRI, but what you see is the adipose tissue accumulation, the fat accumulation, like pericardial fat or any fat in the internal organ. Is there what's your opinion about that? Because it's not very common to do the MRI to investigate on the chronic complication. Thank you.
Yeah, of course, a very important question, how to use all this knowledge. I think the first important remark is that obviously if you do coronary calcium score or EMT ultrasound or whatever you do, you're too late because the disease is already there. So what we want is to have a window on the patient in the stage where we can still treat it and prevent atherosclerosis, organ failure, and this and that. So that's why I think that we need more focus on, for example, inflammation in general, because that is an important component from just fat accumulation to disease. And there are some techniques with MR, but also with multi-energy CT and also PET, but that's more difficult and more expensive to image that. And then the question is, once you know this from mechanistic basic studies and you know, okay, this is an important parameter, but how do we use it in the clinic? I think that is quite easy, and I call that concept opportunistic screening, because everybody gets an examination in the radiology department once in a while, maybe for some abdominal pain or whatever, and many patients, when they reach the age of 50 or even older, they almost all have had one CT, MRI, or even with ultrasound you can do it. And what is the trick then is to use the scan available for some other reason, suspicion of appendicitis or whatever you had in your life, but also the visceral fat is imaged there. Also, the liver fat can be estimated from these scans. So by chance, you have the opportunity to screen people and to come up with a sort of risk calculation and give an advice to the patient and say, well, maybe your fat level in the liver is really high. So maybe visit the internal medicine department or do a lifestyle intervention. So I think that is one way to deal with this knowledge. The other way is what I thought is to do imaging. Yeah, it's maybe complicated. And there are other ways. Once we know what is important in drug trials and in metabolic derangements, then, for example, visceral fat we know is quite important. But there is a trick. You don't have to do imaging. You can just type in your BMI and age, sex, weight, and all these things. And then you also have an estimation of your visceral fat. So that approach. What we do is we try to discover what is important, and then we try to replace that by a non-imaging test or with an opportunistic screening by chance in an imaging test.
Okay, thank you, Prof. Lam. Very interesting. And there is a data that you show me on your lecture about the difference between the Asia and Western population regarding the renal parenchyma and also sinus fat volume. You stated different. Is there any genetic aspect related with those difference, or is there any explanation about the difference?
Yeah, so far, of course, we don't know yet. We did not study the genetic components, and it was also, of course, in a very small group. It was a very small sized trial. It was also sponsored by Novo Nordisk. I saw that they're also in your list there. And yeah, to conduct a large scale study, that's of course really, really expensive. So that's why we focused on the sensitive MR techniques and not so much on the genetics, but there will be a component there. But one other hypothesis that we have and testing in some other studies is that, of course, more or less everybody is the same, but in different genetics makeup, the timing of your disease can be different. So that's what we see in the South Asian people, is that they develop diabetes on an earlier age. So maybe that is the effect that we see, that differences can be explained by just the early onset of disease. So you have a longer history of diabetes and metabolic derangement than compared to other groups. So that is also important, because if that is really true, maybe we should screen, for example, South Asian descent people earlier in life, when they are still in their 20s or 30s, to prevent all the derangement and diabetes, for example.
Okay. Thank you, Prof. Lam.
Can I follow up for your questions, Dr. Giri, from your questions?
Yes.
Yeah. Regarding the difference of ethnicity, Professor Lam, you develop calculation, right, to approximate, predict the visceral adipose tissue. So would it then be applicable in other ethnicity as well, because you develop the formula using the from Netherlands like this group, for example. And what kind of measurement that you use? You using MRI or CT scan?
Yeah, so for this first study, we used MRI, and that was just to quantify the visceral fat and subcutaneous fat volume. But this was only referring to the visceral fat calculations. And it was indeed developed mainly in the UK Biobank also, and the NEO study, what we do combined. So it was really large number of people, but the majority was indeed from Western descent. So I think the next step would be to add ethnicity in the formula and recalculate that. But yeah, maybe that is a nice opportunity to collaborate because you need a lot of data. So if you have a couple of thousand CTs or MRIs, it doesn't really matter as long as you have the abdomen image. Then we can try to adapt the formula. That would be really interesting indeed.
Yeah, thank you, Professor Lam. Thank you, Dr. Biri.
Yeah, very interesting because this session we've been talking from the upstream that the talk delivered by Prof. Lam, also downstream we have Dr. Hari Sakti also talk or discuss about the medication when the complication happen. Can I move on to Dr. Hari, Dr. Diki?
Yeah, sure.
Yeah. Thank you, Prof. Lam. So I continue to Dr. Hari. Dr. Hari, excellent lecture from you that I want to ask is, you mentioned about SGLT2 inhibitor that has benefit in heart failure patient, regardless the diabetic status and also regardless the ejection fraction status. So if patient with heart failure, you just give the prescribe the SGLT2 inhibitor, and then as you said on your talk that the outcome is very good to reduce the cardiovascular outcome. And the problem is most our patient actually has cardiorenal syndrome or patient heart failure with CKD. And is there any suggestion from you? How about patient who is indicated in treatment of SGLT2 inhibitor but has CKD? Thank you.
Okay, thank you very much, Dr. Biri. So, of course, the cardiorenal syndrome is very frequent in the patient with heart failure, and vice versa. Of course, that's also one of the concerns because the SGLT2 inhibitors works at the kidney. So, one of the hypotheses show that if the kidney has a failure or reduce the function of the kidney, also they expect that the SGLT2 inhibitor also will not work because it's mainly work in the kidney. But what we can find actually in this patient in heart failure with chronic kidney disease, of course, in the study they only include in the DAPA CKD patients. We call the DAPA CKD studies. They include only the patient with heart failure and at least a GFR more than 30. And they found even in the patient with the chronic CKD with a GFR more than 30, they found that the SGLT2 inhibitor is safe, and also even further it can preserve the kidney function compared to patients who did not use SGLT2 inhibitors. Although sometimes we have to be very careful because in the study it's shown that at the beginning, at the early initiations of SGLT2 inhibitor, there's a tendency to increase of the creatinine levels in the early, maybe the first week of the treatment. There's an increase of the creatinine level, but after a long-term observations, the kidney function is rather preserved compared to patient without SGLT2 inhibitor. There's several discussion about this sometimes because some of the medications of the heart failure, like such as furosemide, also can affect the reduction of kidney function or the heart failure itself. Or the heart failure improvement in the patient with heart failure reduced ejection fraction can improve the circulatory problems and improve and reduce the cardiorenal syndrome and preserving the kidney. So there's so many actually we can talk and study about why that SGLT2 inhibitor shown that it can have a very good effect not only in the heart but also in the kidney. But for now, the clinical application dictates that if from the CKD studies showed that in the patient with heart failure and at least eGFR more than 30, we can still use SGLT2 inhibitor, and even further, it can preserve the kidney function on those patients. Maybe that's my answer for your questions. So question.
Thank you, Dr. Hari.
Yeah.
Dr. Diki, I think we have audience who raised his hand.
Yeah, Dr. Farid. Dr.
Yeah.
Farid Kurniawan raised his hand. Please, Dr. Farid.
Yes, thank you, Dr. Diki, and thank you, Professor Lam and Dr. Hari, for very excellent lecture. I have questions for Professor Lam and later also for both of you. First questions for Professor Lam is like, you mentioned about the triglyceride plasma, triglyceride content is increased in the heart and also in the liver. I was wondering whether this triglyceride content is correlated with the triglyceride plasma. I don't know whether I missed that or not. And the second question is, if you can measure triglyceride content in this, like say, obesity patients or diabetes patients or pre-diabetes, would you can use it as a predictor of later that these patients will have heart failure, whether just preserve or reduction of the ejection fraction heart failure in the diabetes patients. And my last questions for both of you, Prof. Lam and also Dr. Mulyawan, regarding the SGLT2 inhibitor. If I'm not mistaken, there is no receptor of the SGLT2 in the heart. I was wondering whether if you measure this fat content or this triglyceride content after or before using the SGLT2, whether it will affect the content and it will eventually affect the heart failure itself. Thank you.
Okay, please, Professor Lam.
Yeah, maybe go back to your first question about the triglyceride level in the plasma. We measure that in all the studies, and one nice example is that it doesn't really help is the high-fat diet with drinking cream for 3 days. There we saw an increase also in the triglyceride levels in the blood plasma. In the liver, that correlated to the liver fat accumulation, but in the heart it did not, because in the heart there was no fat accumulation. So we think indeed that the uptake of the lipids by the cells is regulated in a way that we do not fully understand. Also, especially in diabetes, in patients with even normal levels of triglycerides and free fatty acids in the blood, they still have an increased uptake of fat in the cardiomyocytes. So it's not a sort of overload effect of blood lipids, but it's something else. It's upregulation or hypermetabolism or a switch from glucose to fatty acid metabolism in the cell, and then with a higher demand for lipids from the blood. So you cannot use the blood sample to predict the triglyceride level in the organs. Maybe there are other ways to do that, combining other factors. For example, in the liver, we did some studies looking at the CETP, that is a blood marker that reflects the macrophage activity, or actually the Kupffer cell activity for inflammation. And that related a little bit to the liver fat. But there are also other ways of predicting these fat levels in the liver. That's not so difficult. In the heart, we could not do it yet. So yeah, that's a pity. So you cannot use that as a simple blood marker, actually. Second question, what was that?
And for my second question regarding the triglyceride content in the heart, could you use that for the later prediction of the heart failure in diabetes patients?
Yeah, that's of course the $1,000,000 question. Is it useful? So now we are conducting what we call the NEO study, that is the Netherlands Epidemiology of Obesity study, where we are now rescanning patients after more than 10 years. So we included them a long time ago. Now we're doing a follow-up scan in thousands of these patients. And now, since the technique is now developed, we can also add the myocardial fat spectroscopy. And we already did that now in about 500 subjects, and we will go on for, I think, close to 4,000. Then we will follow these patients over time, the next 10 years or as long as they live. And then hopefully we can look back and then predict the value or see the value of the heart fat. We don't know yet, but that is the main one of the main goals of the NEO study. And that took a lot of effort. I think I spent 5 PhD students to convert the technique from about half an hour acquisition time to only 5-minute acquisition time. So it's a quite unique technique that people can copy, or they can get the source code. It's available for everybody. But in our case, yeah, we developed it for a Philips platform. But if you have a Philips scanner, everybody can do it now in a very easy way. So you don't even have to understand how it works, because there are lots of automations and corrections and things going on the background. And that the idea is, of course, that it can also be used maybe when we prove it's useful in a clinical setting. And yeah, your question about SGLT2 drugs, we didn't do any trials, so maybe that's a good question to my colleague presenter.
Okay, thank you, Professor Lam. And now go to Dr. Hari. Please, Dr. Hari.
Yes, thank you. Yeah, actually, there's also one question. Actually, I want to ask Professor Lam whether you have any experience with SGLT2 inhibitors and seeing the fat content also in the heart, because as we know that the SGLT2 doesn't have any receptors in the heart, in the cardiac. So several hypotheses that the SGLT2 can affect the heart is through the metabolism factor, can reduce the insulin resistance, and also apparently the SGLT2 can also reduce the fat content in the liver. So one of the study also shown that that the SGLT2 increase with beta hydroxybutyrate of ketone bodies, and from those ketone bodies increase the bioenergetic in the heart. And another hypothesis also that for some reason that the SGLT2 inhibitor affected the natrium, the sodium hydrogen exchangers, and improve the calcium handling, like in circa. So it can improve the contractility and improve the energy in the cardiac. But for now, we still don't know for sure what is the effect of SGLT2 in the heart. We only know the clinical implication. Somehow the SGLT2 inhibitor can improve the cardiovascular outcome, but still I think we still not clearly know what happened. So I think if possible, again, we can make a collaboration with the SGLT2 inhibitor in the patient and see the fat content. I think it's very, very interesting. So I also interested in the seeking for the bioenergetic factor, whether the SGLT2 inhibitors can improve the cardiac function from the bioenergetic from the ketone bodies, because several studies shown that ketone bodies can also improve cardiac contractility and cardiac function. Whether those actually what happened in the patient with SGLT2 inhibitors, we still don't know. Maybe those maybe those are my answers.
Yeah, maybe.
Okay, thank you, Dr.
If it can add,
You want to add something, Professor Lam?
Yeah, maybe one short thought, because now you have also recently tirzepatide, that is another GLP-1 analog that seems quite potent in reducing the body weight by about 20%. But one of the ideas indeed is to combine that with the SGLT2 inhibitors. So that could be really, really interesting to perform randomized trials to compare separate or combined drug applications for combined effects on cardiovascular, but also on fat distribution elsewhere in the body. That is quite intriguing.
Okay, thank you, Professor Lam. Yeah, of course, there's still a lot of questions, burning questions, but because for the sake of time, we already late from the schedule. Thank you very much, Professor Lam, Dr. Hari, and also Dr. Biri, and all the attendees for the very nice discussions. Hopefully, this session would not stop until today, and hopefully we can also expand collaboration as well, Professor Lam. So Dr. Biri is from the Integrated Cardiac Center from Cipto Mangunkusumo Hospital, one of the biggest hospital in Indonesia. Also Dr. Hari from the Universitas Indonesia Hospital, also from Harapan Kita as well, right, Dr. Hari?
Yes.
Also the
Yes.
biggest cardiology center as well. So hopefully our meeting would not stop here, and we can further collaborate in research also in management. Thank you again, Professor Lam, Dr. Hari, and Dr. Biri, and all the attendees. I would like to close the session, and I would like to give the time back to Natasha. Please, Natasha, time is yours.
Thank you very much, Professor Hildo J. Lam and Dr. Hari Sakti Mulyawan for the very interesting presentation. Thank you as well to Dr. Diki Leverus Tahapari for being our moderator and Dr. Biri Karim for being our panelists. Next, we will now watch a video by our sponsor, AstraZeneca. To the technical team, you may now play the video.
Millions around the world live with heart failure. Yet 1 out of every 2 patients will die within 5 years of diagnosis. For these patients, the risk of CV death and hospitalization for heart failure never rests and keeps them from activities that they enjoy and people they love. Forxiga is a new breakthrough medicine that will change the way patients are treated today. Forxiga can help save more than just life. It can help save the moments that matter. By transforming the standard of care with powerful efficacy to reduce the risk of CV death and hospitalization for heart failure, meaningful symptom improvement, and the seamless convenience of once-daily dosing. Heart failure takes life and what makes life worth living. Now, with Forxiga, we can save life itself.
Once again, we would like to thank AstraZeneca for sponsoring this session. Without the support of our sponsors, CMARS 2023 will not have been possible. Ladies and gentlemen, the next section of lectures is titled Symposium, The Future of Regeneration Therapy in Metabolic, Cardiovascular, and Aging. This time, we are going to be moderated, our moderator, which is Dr. Bramasta Nugraha. Good afternoon, Doctor. Before I give the spotlight to Dr. Bramasta Nugraha, I will now read his CV. Dr. Bramasta Nugraha is from Department of Stem Cell Biology, Cell Therapy R&D, Novo Nordisk, Copenhagen, Denmark. His activities consist of being the researcher at Institute of Regenerative Medicine and Surgery Research, University of Zurich and University Hospital Zurich, project manager at Molecular Parasitology Department, University of Zurich, principal investigator at Cardiovascular and Gastrointestinal IMED AstraZeneca, and senior scientists are specialists in kidney organoids for cell therapy, Department of Stem Cell Biology, Cell Therapy R&D, Novo Nordisk, Copenhagen, Denmark. Without further delay, I will now give the floor to Dr. Bramasta Nugraha. The floor is yours, Doctor.
A very good afternoon and evening and morning to all of you. So for today, I will actually moderate the session number 2 of the symposium for today. So we will have actually 3 speakers. The first one will be Dr. Wataru Kimura from Riken in Japan. And the second one will be Dr. Michelle Nijhoff from Leiden University. And the last one will be Dr. Puspita Anggraini, who is actually my collaborators in University of Indonesia. So actually, interestingly, for today symposium, we have two speakers from the cardiac regeneration.
Doctor, I believe your voice has gone mute.
Can you hear me now?
Yes, we can hear you now.
Apologize, I have problem with the speaker. So a very good morning and evening and afternoon to all of you for today, symposium number 2. We will actually talk about the future of regeneration therapy in metabolic, cardiovascular, and aging. So we will have 3 speakers. The first one will be Dr. Wataru Kimura, who is going to speak actually more on the cardiac regenerations. And interestingly, we have 2 speakers, Dr. Wataru and Dr. Puspita, on the cardiac regeneration. And the second speaker, Dr. Michelle, actually going to talk about the beta islet cells transplantation, also part of regenerations. Interestingly, so it's a combination of cardiac regenerations and the beta islet. So I will give the floor now to Dr. Wataru Kimura from Riken, who's going to talk about the role of oxidative metabolism in the regulations of mammalian cardiac.
Okay, let me start sharing my slide. Can you hear me?
Yes.
And okay. So thank you so much. So, all right. Something is strange. Okay. So, right. First of all, I'd like to thank organizers for giving me this wonderful opportunity to share our research, which is related to mammalian cardiac regeneration, especially in relation to the oxidative metabolism. So as you all know, our heart, the adult mammalian heart, is not capable of regeneration following the myocardial injury, such as myocardial infarction. But in sharp contrast, some other animals, some other vertebrates like zebrafish or newt, or fetal or neonatal mammals can regenerate their hearts. So the question is, what is the difference between these regenerative organisms and non-regenerative animals? And when it comes to the heart regeneration, the most critical, one of the most critical difference between them is the proliferative capacity of cardiomyocytes. So in these regenerative organisms, the majority of cardiomyocytes are capable of cell cycle entry and cell division. So in response to injury, they can enter cell cycle and divide and fix the injury. But in our heart, non-regenerative heart, most cardiomyocytes are incapable of cell cycle entry. So that's why we can't regenerate our heart. And but in mammals, unfortunately, within a short period of time afterwards, most of myocytes start dividing. And that is true for almost all mammals investigated so far, from the small animals, including mice or rats, all the way to the large animals, including pigs. So the question is, what triggers this cardiomyocyte cell cycle arrest that takes place within a very short time after birth? And we have shown that it is actually the activation of mitochondrial metabolism in cardiomyocyte that stops cardiomyocyte cell cycle. And I'll just show you just one experiment that we did because it's published sort of many years ago. Here we put neonatal mice in the mildly hypoxic environment with 15% oxygen for 7 days after birth. And this was actually sufficient to reduce oxidative damage. This is oxidative DNA damage as shown by the 8-oxoguanosine. And that was activation of mitochondrial metabolism in the postnatal heart induces oxidative stress in cardiomyocyte. Actually, that stops the cycle. So when we put them in a hypoxic environment and limit the availability to atmospheric oxygen, there's a reduction in oxidative damage. And that was sufficient to continue cardiomyocyte cell division in the neonatal mouse heart, as shown here by the increase in the number of Ph3 positive cardiomyocytes. So based on this idea, we asked whether the reduction in oxidative damage, oxidative stress by putting mice in a hypoxic environment by using this hypoxia chamber, whether that's sufficient to induce myocyte proliferation in the adult heart or not. So to test this, we induced MI, myocardial infarction, to adult mice and then exposed them to 7% environment with 7% oxygen for 2 weeks. And that was actually sufficient to reduce oxidative damage in cardiomyocytes, as shown here. Here's a control, and this is hypoxic cardiomyocytes. And that induces myocyte proliferation, as shown by the increase in the rate of Ph3 positive proliferating cardiomyocyte in hypoxic cardiomyocyte. And then that was also sufficient to induce functional recovery, the recovery of the LV systolic function. So this is a ejection fraction measured by echocardiography. Here's a baseline, and this is 3 days post-MI. And then when we expose the one group of mice with hypoxia, there's a significant recovery in the LV systolic function. So there seems to be the trade-off between mitochondrial metabolism and myocyte proliferation or cardiac regeneration. So when we are fetus or neonates, the mitochondrial metabolism is suppressed at a low level, and thereby myocytes are protected from oxidative stress, and then they can proliferate and they can regenerate themselves. But after birth, they start to utilize atmospheric oxygen and they activate mitochondrial metabolism. Myocytes are exposed to so much oxidative stress, and then they stop dividing, and then they can't regenerate the heart anymore. But if we reduce the mitochondrial metabolism by exposing mice to a hypoxic environment, we can sort of partially reprogram cardiomyocytes into a fetal-like proliferative state. So the next question is whether that's what is the mechanism, molecular mechanism behind it. But identification of molecules that are responsible for this sort of state transition is not so easy, because the birth itself or exposure to hypoxia changes almost everything. That causes a lot of noise when we compare, for example, gene expression. So to identify the molecular mechanism behind it, we wanted to use animals in which the timing of birth is different from the timing of cardiomyocyte cell cycle arrest. So that's why we start utilizing the marsupial opossum. So here's a opossum neonate, because marsupials are known to be born very immature state. So this is what we use is a animal called the gray short-tailed opossum, and this is a P1 postnatal day 1 opossum neonates. And as you can see, they are very tiny and immature. And they're known to be equivalent to embryonic day 11.5 to 13.5 in mice, which are like this. So you can see how immature they are when they are born. And 2 weeks later, now they look like P1, postnatal day 1 mice. And then this is 1 month old, and this is young adolescent opossum. So how about the cardiomyocyte proliferation? So to compare myocyte proliferation in mouse neonate and opossum neonate, we just immunostain them with pH3 and troponin, the marker for proliferation and cardiomyocytes. And here's the comparison that we did. So in mouse neonates, which are shown in blue, from P1 postnatal day 1 to day 7 to day 14, myocyte proliferation, the rate of pH3 positive myocytes goes down close to 0 over 2 weeks after birth. But whereas in the opossum, even 2 weeks after birth, the rate of myocyte proliferation is kind of equivalent to that of P1 mice. So they continue to divide even after birth. And then it goes down and down, close to 0 over 2 months after birth. And because in mice, they lose their regenerative capacity in the heart from somewhere between P1 and P7, we postulated that maybe opossum maintain the regenerative capacity over 2 weeks after birth, and then they lose it over a month after birth. So to test this idea, we just compare the regenerative capacity in the neonatal opossum at P14 and 2 weeks after birth and 1 month after birth by permanent ligation of LAD to induce myocardial infarction. So this is LV systolic function, the serial echocardiography, and ejection fraction. When we induce MI at P14, 2 weeks after birth in the opossum, ejection fraction goes down significantly, but it recovers completely over a month after the injury. But when we induce MI at P29, the recovery is not, that didn't happen. So the regenerative capacity seems to be lost 1 month after birth. And same is true for the histological analysis. So when we induce MI at P14 and waited for 1 month, there's almost no fibrotic scar in the infected area. But when we induced MI at P29, 1 month old, and then waited for another month, there's a huge fibrotic scar in the infected area. And when we looked at cardiomyocyte proliferation after the MI surgery, so when we induced MI at P14, and there is a significant induction of myocyte proliferation compared to sham operated ones. But when we induced MI at P29, there's almost no change in the rate of myocyte proliferation, suggesting that there's no regenerative response at in 1 month old heart as opposed to 2 week old heart. Okay, so this shows that the possum is what we are looking for, because the timing of birth is different from the timing of cardiomyocyte cell cycle arrest. So now we can focus on the timing of cardiomyocyte cell cycle arrest and then compare the gene expression before and after. So it was fortunate for us that this paper has been already published, in which the authors looked at compared the gene expression in many animals, including opossum, in many tissues, including the heart, at various time points from embryonic days to all the way to adulthood. So we reanalyzed their data, and to make a long story short, what we found was that there is a signaling pathway called AMPK, which is upregulated in when cardiomyocytes stop dividing in the opossum heart. And this AMPK signal doesn't show up when we take a look at the opossum mouse heart. Transcriptome was the mouse heart, so that we can fully take advantage of the opossum. So we just confirmed that whether the AMPK signaling is upregulated or not in the mouse heart, neonatal mouse heart, and the neonatal opossum heart. And so red signal is phosphorylated AMPK alpha, which is a marker for activated AMPK signaling. So in the mouse heart at P1, when myocytes are proliferative, there's no signal of AMPK activation in proliferative cardiomyocytes. But at P7 and P14, when myocytes stop dividing, there's activation of AMPK signaling in cardiomyocytes. And same is true for the opossum. At P14, when myocytes are proliferative, there's no signal of activated AMPK. But 1 month and 2 months afterwards, and when myocytes stop dividing, there's an activation of AMPK signaling. And so we asked whether the suppression of AMPK signaling, whether the suppression of AMPK extend the postnatal cardiomyocyte proliferative time window or not. So to test this, we injected the chemical inhibitor against the AMPK into neonatal mice and neonatal opossums. And as a result, both in mouse and opossum, suppression of AMPK was sufficient to induce the myocyte, continued myocyte proliferation in the postnatal heart. Okay, so these are published data. And the next thing that we want to know is what is the downstream of the AMPK signaling. So it's already known that AMPK activate the mitochondrial metabolism. And as I told you in the very beginning, mitochondrial metabolism is responsible for cardiomyocyte cell cycle arrest. So obviously, this is a myocyte. The mitochondrial metabolism is the obvious candidate for the downstream of AMPK signaling. So these are. I'm going to show you some preliminary data that indicates AMPK suppresses mitochondrial fission, the fragmentation of mitochondria. So to suppress, to activate mitochondrial metabolism. So mitochondrial fission is induced by activated form of DRP1. And when we stain neonatal mouse heart with mitochondrial, with phospho-DRP1, which is activated form of DRP1, you can see that from P1 to P7 to P14, so these are neonatal mouse heart. So from P1 to P7 to P14, when myocytes stop dividing, there's a downregulation of phospho-DRP1, meaning that there's a suppression of mitochondrial fission in the postnatal heart. So we ask whether what happens if you block the AMPK signaling? What happens to the mitochondrial fission? So when we inhibited AMPK signaling with a small injection of a small molecule inhibitor against the AMPK, there's an increase in number of phospho-DRP1 positive cardiomyocytes, indicating that mitochondrial fission is activated when we suppress AMPK signaling. And what happens when we induce mitochondrial fission in the adult heart? So to test that, we overexpress the constitutive active form of DRP1 in the adult mouse heart, and turned out that it was sufficient to induce myocyte proliferation in the non-proliferative cardiomyocyte. And obviously, we're asking whether that is sufficient to induce cardiac regeneration or not. That's what we are working on right now. So that's all I have. In summary, we've shown that oxidative metabolism triggers cardiomyocyte cell cycle arrest in the postnatal heart. And we've also shown that opossum neonates retain myocyte proliferation and capacity for cardiac regeneration for 2 weeks after birth. And then by looking at the transcriptome of opossum heart, and we identified AMPK signaling as a regulator of cardiomyocyte cell cycle arrest. And that might control the mitochondrial fission. Okay, that's it. So these are lab members and the collaborators and the funding source. Thank you so much.
Thank you very much, Dr. Wataru. Now I will invite any questions from the audience. If not, I will ask my questions first. I will check first in the chat. No, I don't think there is one. So I would like to ask, is there any study for let's say, focusing on the AMPK signaling in cardiomyocyte in vitro, like using primary cells or iPSC-derived cells to prove the same concept to actually control the mitochondrial fission?
I don't think there is any study that shows the direct connection between MPK and mitochondrial fission, especially in cardiomyocyte. But it has shown that one of the regulator of mitochondrial fission, which is called MFF, is a direct substrate of the target of the phosphorylation of MP kinase. So I think that it is very likely that they are the direct target of MPK, but it's not shown in cardiomyocytes.
I see. Thank you. I would like to open again the questions from audience, if there is any burning questions.
Yes, seems to one hand.
Yeah.
Yes.
Go ahead, Dr. Again.
Thank you very much, Dr. Prasmasta, and thank you very much for your wonderful presentation, Dr. Kimura. Nice presentation as always. So I was wondering, have you tested your hypothesis in like MPK knockout mice to validate your hypothesis?
Yeah, that's a good point. So we have generated conditional knockout of MPK alpha and also alpha 1 and 2, and in both cases we can see the extension of the proliferative window in the postnatal cardiomyocyte. But unfortunately, when we knock it out in the adult mice, there's no activation of the myocyte proliferation. So I think that MPK is a trigger, but it doesn't remain to be active throughout adulthood. So probably we need to identify downstream factors that induce maintain myocyte cell cycle arrest in the adult heart. So that's what we are doing right now. Very nice question. Thank you.
Thank you very much. Very interesting. Thank you.
Dr. Kimura, I would like to ask just, it would be a naive question. Since you mentioned about the hypoxic conditions on the beginning of your presentation, is there any off target for other organs that you experience?
No, that's very kind of everybody wants to know, their favorite organs, what happens to the brain, what happens to the kidney. That we haven't looked at them, but when it comes to the oxidative damage, we compared oxidative DNA damage in multiple organs, but the heart is especially got really high oxidative damage. Always have the high oxidative damage at higher level. So probably the heart is probably one of the most beneficial sort of thing. If you expose them to hypoxia, heart would be heart would show a drastic change in terms of the oxidative damage. So I'm not sure whether the same thing happens in the other organs, probably the heart specific.
Okay, thanks. There is a question from, okay, maybe just one more question, Dr. Agian, then I will move to the second speaker. It's from Nafis S. Adnan. The question is regarding cardiomyocyte remodeling in opossum. In mice, does the conducting cells get regenerate as well? I
see. That's a good question. That we haven't looked. It's very interesting. What happens to the pacemaker? What happens to the conduction system? It probably, if it sort of over proliferate, that would be harmful. So I think it's a really good point, and we'll take a look at that. Thank you so much.
Thank you again, Dr. Wataru Kimura. So we can move on now to the second speaker, Dr. Michiel Nijhoff from Leiden University. He's going to present about the pancreatic beta cells regeneration in diabetic patients, focusing in islet cell transplantation. I will then give the floor to you.
Yeah, thank you. And thank you for pronouncing my name correctly. That's actually quite rare outside of the Netherlands. So my talk will be quite a bit more clinical about islet and pancreas transplantation as treatment for type 1 diabetes. And when we're talking about type 1 diabetes, it's actually quite different than type 2 diabetes and metabolism, but I think it might be more relevant than you think also for you. And talking about type 1 diabetes, it's all about insulin, of course. So type 1 diabetes, can you all see my presentation? It's difficult for me to see. Yeah, okay. So short overview, type 1 diabetes and why to transplant, pancreas transplantation, which is sort of the old paradigm, and then islet transplantation and what happens there, how it works, and where we're going. So why to transplant? As you might know, type 1 diabetes is an autoimmune disease. The islets in the pancreas contain beta cells that produce insulin, and these beta cells are destroyed by your own T cells, mostly by your cytotoxic T cells, which leads to a loss of endogenous insulin production, hyperglycemia, ketoacidosis, and if you don't treat it, you will die. Symptoms are elevated glucoses, and you have signs of autoimmunity. What's important is that you require lifelong insulin therapy. You can't do without it. And actually, it's only been 100 years since we've had insulin. Before, this was sort of a disease with a very short prognosis. It's also important to realize that this disease starts at a fairly young age. So there's a lot of life years where you are suffering from diabetes. In the Netherlands, the prevalence is around 1 in 150, so that's around 120%. I did look up the prevalence in Eastern Asia. It's lower. It's a bit lower in Japan and a bit even more lower in Indonesia, but still, the WHO describes that around 25% of new cases with type 1 diabetes are from Southeast Asia. So it's becoming more prevalent, probably due to social economic factors that are changing. And if you calculate this with the number of people, then there's 9 million patients worldwide suffering from type 1 diabetes, and around 1 million of these are in Japan and Indonesia. So it is quite relevant also, despite type 2 being a bit more prevalent in Asia. So the mainstay treatment, like I said, is insulin. You can use mixed insulin regimens. You can use short and long-acting insulin. You can use pumps with continuous insulin. And that's how you treat it. And you use some sort of long-acting insulin as a base. So the base to make sure that there's a basal level of insulin that we all have. And then you use insulin around mealtime to cap the carbohydrate-induced hyperglycemia. And this can be quite tricky because it's difficult to predict. And insulin treatment is associated with some glycemic instability. And what I mean by that, this is a person that does not have diabetes. And you can see the glucoses are quite strictly between 3.5 and 8. If you want to go to milligrams per deciliter, it's just 17-fold. But so these are quite stable blood glucoses. Still in the evening and night, it's more stable than during the day because you eat. And here you see a patient with type 1 diabetes who is considered well regulated. He's got a nice HbA1c around 7% or 50, and he doesn't have severe hypoglycemia. But you can immediately appreciate this instability of the glucose levels going up and down. And if you would intensify the treatment here, the patient would get hypoglycemic episodes. And this instability leads to problems. And we know it leads to mortality, because even if these patients are well regulated, which is this group, then you can see that mortality is around a 3-fold increase, mostly from cardiovascular disease. And it's get much worse if your regulation is worse. And the instability goes down and up. Down is hypoglycemia, leading to symptoms of neuroglycopenia. So your brain is deprived of glucose, in the end leading to loss of consciousness, and symptoms of contrarregulation, mostly adrenaline and glucagon. And there's many reasons why glucose can get too low. Maybe you injected too much insulin, maybe you ate less than you expected, maybe you exercised a bit too much. But every time you have a hypoglycemic episode, your awareness decreases, and you will notice it later and later. And at some point, you won't notice it at all. And that is a risk factor for severe hypoglycemia, meaning you completely lose control. You might lose consciousness. You might lose consciousness while driving a car. You might not be able to control yourself, and your behavior may change as well. And this is a major problem in diabetes regulation, because the fear of these hypoglycemic episodes, the fear of this severe hypoglycemia is a major limitation in controlling the glucose levels. And it leads to anxiety and reduced quality of life. The other side is the hyperglycemia. Tricky here is that it generally only leads to symptoms of glucose levels are fairly high. Then you will get polyuria, blurred vision. And in severe cases, ketoacidosis, which is, of course, a life-threatening condition. But the mainstay problem here in the long term is the complications, which are known also in type 2 diabetes, of course. You get microvascular disease, you get cardiovascular disease, and in pregnancy, you get a lot of pregnancy-related problems also with the child. So these complications, they don't always occur, but they are dependent on predisposition next to glycemic control, and they occur after around 10 years. They're irreversible. Many of these have been mentioned, but at least in the developed world, diabetes is the leading cause of blindness, kidney failure, and it's an important cause of cardiovascular disease. But what we consider as one of the most important problems in type 1 diabetes is the unawareness to hypoglycemia, which strikes in up to 2/3 of patients and which leads to a lot of problems, also simply in daily life. So when we're treating these patients at the outpatient clinic, we focus on quality of life and a lot of things to focus on: chronic disease, dealing with injections, dealing with hypoglycemia, preventing glycemic deregulation, and preventing long-term complications. But in the end, even with the most modern treatment options that we have with pumps, sensors, and everything, only around a quarter achieves these treatment targets. And currently, only beta cell transplantation is the treatment that actually reduces hypoglycemia and reduces high HbA1c. Technology is coming close, but it suffers from the problem of subcutaneous insulin administration. And what I mean by beta cell transplantation is every type of transplantation where new beta cells are introduced, and they can be beta cells from a stem cell source, they can be islets isolate for a pancreas, there can be a whole pancreas, any type of beta cell that is introduced that actually has glucose responsive insulin production. So the mainstay here at the moment is allogeneic transplantation. And allogeneic meaning that as a person with type 1 diabetes, you get a transplant from another person, a deceased person generally. This is the scheme that's most well known. Mostly it's patients with type 1 diabetes and kidney failure, seeing on the left. And the most important treatment here is simultaneous kidney and pancreas transplantation. It has the best outcomes. Sometimes when a patient's already on dialysis and there's a living donor available, you could opt to first do the living donor kidney transplant and then do pancreas after kidney. But there's also some patients who have such severe type 1 diabetes, so many complications, so many problems that they are willing to just do the pancreas transplant to get rid of the diabetes despite the immunosuppression involved. And then you could do a pancreas alone transplant. But like I said, the mainstay is simultaneous pancreas kidney in patients with diabetes and renal failure. And this is a whole organ transplant. It's a combined transplant, and these are relatively young and fit patients. They are below 50-ish. They have a BMI below 30. They have limited comorbidity. And here in the Netherlands, we do around 30 per year. Worldwide, it depends on the centers. In America, in the United States, it's a very common procedure, hundreds per year. And the alternative is a pancreas alone. For example, someone had a kidney transplant, or for example, patients with severe hypoglycemia problems, or patients who are about to turn blind and they are unable to improve their regulation. And here we actually do treat them first with pumps and everything we have, of course. It's important to note that these patients get potent immune suppression. So alemtuzumab is lymphocyte depletion, and they get combined modern immunosuppression, but also sometimes azathioprine or cyclosporin is used. And it's a major surgery because this entire pancreas, you can appreciate here in the right fossa, is transplanted together with the duodenum. It's placed generally on the intestine, but can also be placed on the bladder. And the pancreas is a difficult organ to deal with. It leaks easily, it gets damaged easily. And then when enzymes leak, it can lead to a lot of intestinal complications. When the kidney is also transplanted, it's transplanted on the left side, and then it's a combined transplant. But this procedure is quite effective in treating type 1 diabetes. However, there's a lot of complications involved, and these patients generally have a prolonged hospital stay. They have multiple surgical and abdominal complications, such as infection and thrombosis. And in at least 10% of patients, the pancreas has to be removed again. But as you can appreciate here, at first there was a steep learning curve, but around when the new millennium started, the outcomes stabilized, and we could see that in the long term, around 70 to 80% of patients were insulin independent, so their diabetes was in remission with this treatment, and that's still roughly the number that we see today. The alternative here is islet transplantation. So here you can appreciate some pretty stained islets, stained red due to diazone. And islets can be isolated. There are small clusters of cells, and they have a different adhesivity than the rest of the pancreas. So instead of a pancreas after kidney, you could do islet after kidney. So a patient with a kidney transplant. There's even a possibility of doing a simultaneous islet kidney, but most centers don't have that option simply due to regulation. And then there's also the possibility of doing an islet alone transplant in patients with complicated diabetes. So here you don't have to take the entire pancreas. You can just take the islets, and it's a much easier procedure for the patient. It's much more difficult for us because we have to isolate these islets. In the Netherlands, DLUMC, which is where I work, of course, is the only center that performs it. We do around 10 per year and around 125 total. I checked in Asia. Japan has 50 total islet transplants, South Korea 35. China is a bit uncertain. They are not forthcoming with their data, but around 50. And also Australia is actually sort of the same as the Netherlands in numbers. So it's not in Indonesia, for example, but there are adjacent countries that do it if there's a reason when you want this. If a patient already has a transplant, there's a fairly low threshold to do an islet transplant because you actually protect the kidney transplant with these islets, and you can use it as an alternative to the simultaneous pancreas kidney. There's also patients who have severe hypoglycemia unawareness despite modern options and who do not want the big procedure of an entire pancreas. And for example, a patient that was referred to me, she told me that she could have a severe hypoglycemia at the most random moments, and then she would simply lose consciousness. She would have a glucose level of 1, and she would need help from outside, but she was alone and she lived alone. So what she did is her entire house was fitted with webcams, and her friends and family, they each took turns to look at these webcams and see whether she wasn't losing consciousness at some moment, and then go there and inject glucagon and get her out of the hypoglycemia. You can imagine if it's that severe that there's no way of living really. You can't do anything because at any moment you can lose your consciousness. It's important also to realize with islet transplantation that the goal is not so much to completely bring the diabetes into remission. It's nice if it happens, but it's not our goal because it takes too much islets. The goal is glycemic stabilization and remission of hypoglycemia actually. And I will show you glycemic stabilization in a minute. So it's different in that regard to pancreas transplant. So like I said, we can isolate islets from a donor pancreas, and the first panel is the donor pancreas being removed from the donor. It's put on ice, it's called ischemia, and when it comes to us in the fourth panel, we inject a catheter into the pancreatic duct, and we just infuse it with an enzyme, collagenase, and the entire organ is saturated with collagenase. But because it's cold, the collagenase isn't working yet. So when the collagenase is entirely through the pancreas, we actually cut it in pieces and put it in a special chamber that you can see at the bottom of panel 5. And this chamber, we simply pump warm water through it, activating the enzyme, and the enzyme starts digesting the pancreas. We take samples every minute or so, because the trick is that you want to digest the pancreas so much that the exocrine tissue is digested away from the islets, but the islets are still intact. And if you stop the digestion too early, then you get islets that are still embedded in exocrine tissue. If you continue for too long, then your islets will be digested. So it's a tricky, that's actually the tricky part of the isolation and the most important part. And when we find that optimal moment where the islets are loose from the exocrine tissue, but they are still intact, then we inject cold water again, inactivating the enzyme. We harvest the product, which is a digested pancreas with islets in it. And we use a centrifuge, a gradient separation, to separate islets from pancreatic tissue. The islets are lighter, so they can be separated. In the end, we can isolate around 70% of the islets from the pancreas without too much problems, and that's generally around 3 to 4 milliliters of tissue. So the pancreas, which is around this big, is reduced to 3 to 4 milliliters of tissue, which can be suspended in an infusion and infused into the portal vein, into the liver. So when we have this islet product, of course, we need to test it first, test for compatibility, but also function. The advantage here is that you can actually just put these islets in a well and just add glucose and see whether there's an insulin responsivity or not, and add low glucose, because then they should not be secreting insulin, because then they will be autonomous, and of course that's not what you want. So this is what we call a glucose stimulated insulin secretion test. And here you can see an example of islets responding with a two-phase response to glucose. Again, immune suppression, important. It's again quite strong immune suppression, but the procedure itself is a lot easier. The intervention radiologist cannulates the right portal vein, shown here, puts the catheter inside the main portal branch, and the islets are infused and they go into the liver. And people always say, well, why the liver? The biggest reason is that the liver has a vein going into it. All other veins go away from your organs, and then the islets would go into the lungs. And then you would have to do it into the arterial circulation, and you would embolize the organ. The pancreas is much more difficult to find and much more dangerous as well. The liver easily regenerates more new veins for these islets, and it's simply easy. Many other places have been tried, up to bone marrow, the eye even, but still the liver comes out best. And an islet transplant looks like this. So the patient here is conscious, and there's a local anesthesia, and this is a needle used to put the catheter into the portal vein. And this is the intervention radiologist, and this is the catheter that's used. It's a fairly wide catheter because islets are quite wide. You can see here the portal vein and the portal branch nicely enhancing with contrast fluid, and then we know the position is correct, and we can take our islet bag, which is simply an infusion bag where the islets are suspended, and we hook it up to the catheter and we slowly infuse it. You can see the islets going, they're around the size of grains of sand. So these are all islets going into the patient, going into the portal vein, up into the liver, and they lodge into the portal vein sinuses, where they require around a week or so to get new veins and start producing insulin. So it's a very easy procedure, it takes around 20 minutes, low complication rate. And in our hands, there's about 90% long-term graft function. So around 90% of patients have a long-term endogenous insulin production. And when they have endogenous insulin production, again, severe hypoglycemic episodes are almost completely abrogated, and there's improved quality of life. And these data are somewhat comparable to most other large centers, also, for example, in Japan. So I mentioned before the glycemic stabilization, and I mentioned the patient that had random hypoglycemic episodes and needed help from other people all the time. And what we do in these patients before we transplant them is we do a 24-hour glucose monitoring. And in this patient, it looked like this. You can probably appreciate that she does not have a good time in range. All the time that she spends with her glucose level in normal range is going either down into hypoglycemia or up into severe hyperglycemia. And this is what we call glycemic instability. There's no stable glucose levels in the normal range. You go down into hypo or you're very high. And her average glucose level is way too high, causing all the problems associated with that. But if you were to try to lower it, you would lower her entire glucose levels, and she would have even more hypoglycemic episodes. So this patient had a single islet transplant, and this is what her sensor output looked like after. And this is with insulin. So she wasn't off insulin, but she had very stable glucose levels. And that's really the point of the procedure. And this stabilization does a few things. Some patients become insulin independent, in most centers up to 50%, So it really depends on whether you go for insulin independence or not. Sometimes when a patient's happy with some insulin, you can also opt not to do a second transplant and transplant someone else instead. And we also are a bit more reluctant to go for insulin independence because we know that most patients require some insulin again within the first 2 years. So it's not really the biggest advantage of this procedure. The advantage is the very nice reduced HbA1c, the glycemic stability. And here you can see the importance of endogenous insulin production. This is the DCCT trial. It's a bit older trial studying long-term outcomes of diabetes treatment. And you can see that even low levels of C-peptide, these are levels of C-peptide where the patients themselves don't even notice they have endogenous insulin production, have a linear reduction of, on the left side, retinopathy, and on the right side from 0.135 C-peptide, which is microscopic insulin production, a linear reduction in hypoglycemic events. And that's also shown in islet transplantation. Here you see in these panels, you see a beta score. Beta score is a measure of how well the transplant functions, 0 meaning no function and 8 meaning optimal function. And all metrics associated with glycemic control are linearly improved. Being glucose takes a bit longer, but for example, standard deviation is a linear reduction. Standard deviation of glucose is a linear reduction with beta cell function and also hypo and hyperglycemia. Complications, actually the only complication we see is bleeding. We've seen 4 patients with relevant post-procedural bleeding, sometimes requiring a blood transfusion or a surgeon because there was a small vessel bleeding near the puncture spot. Of course, we see infections because they get immune suppression, and we see some rejection and graft failure in the first episode. It's important to note that we generally use more than one organ, and these are organs that are discarded for whole organ transplantation. So very briefly about future perspectives of islet transplantation, it's important to realize that rejection is difficult to diagnose. We do have studies looking at this where we think we can diagnose rejection by clinical parameters, but you can't biopsy. If you biopsy the liver, you get like 1 islet. You still don't know whether there's rejection. And there's a big problem with long and short-term loss of islets. In the short term due to inflammation and hypoxia, and in long term due to chronic hypoxia, immune suppression, and recurrence of autoimmunity. And of course, the immune suppression itself is a big problem, and donor shortage. In the Netherlands, for every 30 new patients with type 1 diabetes, we have 1 donor pancreas, and it's probably not better in the rest of the world. So a problem is beta cell ischemia, hypoxia, and some studies are done with scaffolds. Scaffolds is simply a bio device where islets are loaded. And in this example on the right here, the islets are loaded in a module, and there's a membrane around the islets that's permeable to glucose and insulin, but not for the immune system. And there's an oxygen module where the oxygen is actually pushed into a model in the middle, and high oxygen concentrations here help the islet survive. You can see a picture here of a patient with this device, which is around the size of a hockey puck. It's placed on the peritoneum, and there the beta cells or the islets can interact with the bloodstream without being subjected to the immunity and with the oxygen supply here. And this has been shown to actually yield to some C-peptide production. In this case, they put in porcine islets, but you could also use other islets, of course. And this is really a work in progress because it's quite tricky to get a membrane that won't elicit some foreign body response, that's permeable to glucose and insulin, but not to antibodies. So it's a work in progress. And there's also the possibility here of microencapsulation, where you actually give each islet a gel layer that's permeable. This suffers from the same problems. The advantage here is that the bloodstream itself will provide oxygen to the islets. You could also go for tolerance. Here in the Netherlands, we've done a study with tolerogenic dendritic cells, where we actually demonstrated that tolerance could be induced to diabetes. And one last thing I want to mention is the donor organ shortage. There's many options here. Xenotransplantation is actually being explored in Korea right now, where they're actually doing studies with modified pigs, where they actually isolate islets from those pigs and put them in a scaffold so they could be retrieved if there's some sort of virus infection or something else. But you could also generate beta cells, and it's beyond the scope of this presentation, but there's actually a lot going on in that area. And there's been a lot of trials, and this has sort of all led to the development of a startup business called Vertex. And they have been able to produce beta cells from embryonic stem cells, and they call it VX880. And actually, last year, the first 3 patients have been transplanted with these embryonic-derived beta cells. And that's actually quite a big event. Because 20 years ago, when I started studying medicine, they already told me that type 1 diabetes would be treated with cells in the near future. So it took 20 years, but it's happening. And they are rolling out this study in the rest of the world. So they will also be doing this here in the LUMC. I'm not sure whether it will also happen in Australia. But the first 3 patients that have been transplanted are doing well. And one of them is off insulin and the other 2 are doing well. So we actually have our first stem cell-derived beta cells being used in patients with type 1 diabetes. So this is a big paradigm shift. So to conclude, type 1 diabetes, exogenous insulin treatment is required. It leads to improved glucose levels, but not true glycemic control. And you are not able to prevent complications. Patients may suffer from severe hypoglycemia with a major detrimental impact on quality of life. So we need to still be looking for better treatments. An islet transplantation is a way to reconstitute endogenous insulin production, reducing hypoglycemia and complications. It's an easy procedure, but it does require immune suppression, and the islets suffer from attrition. But we are getting to places where we might actually make our own islets and maybe even protect them from the immune system. So I'm happy to take questions. If you find this topic interesting, there's an entire curriculum on pancreas and islet cell transplantation available on the IPEDA website from the Transplant Society. There's also a few interesting papers to read to get some more background, if you like.
Thank you, Michiel, for the very nice presentation from the clinical perspective. So now I would like to open questions to the floor. Maybe I can start first, because I think Dr. Agian also mentioned that we can also, again, have a discussion later, but maybe I will ask questions now. Like, I'm not working on the endoderm lineage at Novo Nordisk, but I have many colleagues actually working on the beta islet. I'm from the mesoderm lineage, but I'm just wondering, I'm curious about when you actually isolate beta islet from pancreas, what kind of donor? Is it from cadaver or is it from living donor patients? Or
theoretically, you could do living donor. So it has been described that parents actually donate their pancreas tail, not here actually, but in other places. And but it's a very dangerous procedure for the donor, because removing a pancreas tail can lead to a lot of complications. You get leakage of the exocrine enzymes, and they can actually start digesting the person inside, so to speak. So we don't do it because we feel it's unethical to subject a donor to those risks. So we use cadaveric donors, and they are highly selected. So they of course they have to have normal HbA1c levels. They have to have a relatively range. They can't have like damage to the pancreas, for example, from a car accident. And actually in the Netherlands, our donors are not that high quality because they're generally older people who've had like cerebral hemorrhage, for example. In the United States, they have a lot of younger donors because of the gun violence, sadly, I guess, but they do have much better quality donors leading to better outcomes. But yeah, the donor selection is quite tricky, more tricky than in kidney transplantation, for example.
There is someone with raising hands, Dr. Farid Kurniawan, go ahead.
Yes, thank you, Dr. Bramasta, and thank you, Dr. Naiha, for the very interesting lecture. I have several questions regarding your lecture. First is the choose of the patients, like the choosing of the patients. Is there any patients with type 1 diabetes that is not suitable for this islet cell transplantations, and what are the criteria? That's my first questions. And my second question is, you mentioned about the using of the heterogenic dendritic cells for reducing the rejections. How good is the result is for this islet cell preservation? And is there any role also for the mesenchymal stromal cells? Because I've noticed, if I'm not mistaken, they also use this mesenchymal stromal cells for kidney transplantation to reduce the rejections. And my last question is regarding the type 2 diabetes, whether there is a role of this islet cell transplantations in the type 2 diabetes patients. I notice it might be very small because most of them are like highly insulin producing patients, but maybe in very end spectrum of their diseases. That's my questions. Thank you.
Yeah. Well, thank you. Quite some questions. So the criteria for islet transplantation, the criteria, in the end, everyone could get islets. The big problem is the immune suppression, and it's quite potent immune suppression. So the downsides of the immune suppression have to weigh up against the upsides of the transplant. So if a patient is injecting insulin and is actually doing fairly well and not having too much problems, then the problems associated with the immune suppression probably don't weigh up to it, because especially after 10 years or so, you get malignancies and you get quite severe infections, and it's difficult to titrate and it has side effects. So the most important reason to transplant generally is when a patient has kidney failure, and then they already have immune suppression and they have all these complications. And we know that if you transplant a kidney in a patient with diabetes, also with type 2 diabetes, that outcomes are poorer than when you transplant a kidney, for example, in a patient with cystic kidney disease. And that's because the diabetes is still there. It's still damaging the kidney. It's still causing cardiovascular disease. So one major indication is that. The other major indication is patients who have such problematic regulation that it impacts their quality of life in such a negative way that it offsets the downside of immune suppression. And generally, that's patients with severe hypoglycemia problems, because if you have this problem, it's really much more severe than most people realize. You really can't go outside. You can't drive a car. You can't work. You can't. I had actually a woman who had a child who couldn't care for her own child because when she had a hypoglycemia, she would just drop the child. So these patients, they have major beneficial effects from this procedure. So those are the most important criteria. There are some other criteria. For example, I had a person who only had one eye and he had a retinopathy in it, and he was unable to regulate his diabetes, and he would go blind if he wouldn't do something. So that's of course, going blind, of course, is worse than taking immune suppression. As for the tolerogenic cells, the study we did actually here, because I also do a lot of type 1 diabetes research, we did a study where we generated tolerogenic dendritic cells in our lab with dexamethasone, vitamin D analogs, and some other tricks. We made them tolerogenic to the proinsulin signal that's actually presented by stressed beta cells, so early type 1 diabetes, and we administered these to patients with type 1 diabetes in an early phase to see whether it would stop the autoimmune process. And it's in very, very early days. The reason I mention it is that if it works, it's actually something that we could expand into many other areas, and we are starting a phase 2 trial now. The mesenchymal stem cells, yeah, so I know it's used in kidney transplant. I actually know Marliese Reinders quite well, who also did a lot of these studies. There are some centers who are thinking of doing this because it's quite easy to also infuse these mesenchymal cells into the portal vein, because it's the same spot really. But I don't know if anyone who has actually done it in humans, at least. I know there's some rat studies that show some promising results, but not in humans yet. But yes, the same principle holds definitely. Yeah. And type 2 diabetes. So there's actually quite some literature on pancreas transplantation, type 2 diabetes. The upside of pancreas transplantation, you get a lot more endogenous insulin production, and the islets are still vascularized. They generally survive longer, so they will be able to overcome the insulin resistance in type 2 diabetes, so to speak. Islet transplantation in type 2 diabetes will mostly be indicated in patients who have been able to reduce their insulin resistance problem, for example, reduce their weight or use metformin or whatever, because insulin resistance is really a big contributor to demise of islets, because these islets are out of their own system, their oxygen supply is not as good as when they're in the pancreas. So they won't be able to overcome the insulin resistance, and they will suffer from the attrition more than normal islets, so to speak. So we know that patients with insulin resistance, they have greater attrition of their islets, so greater reduction of their islet function in the longer term. So we would only consider that in patients who actually have overcome their insulin resistance somehow and who have significant insulin deficiency. What I think might be more important than you realize is that there's quite a few people walking around that have the diagnosis type 2 diabetes, and they might actually have type 1 diabetes, simply because they were like around 25 or 30 when they got it. And especially in Indonesia, type 2 diabetes is simply much more common. So many physicians would just say, well, you have diabetes now, and that's it. And there actually might be quite some people who actually have type 1 diabetes, because it's becoming more common in Indonesia as well. I read the WHO report for this presentation, and it's actually, like I said, a quarter of new patients type 1 diabetes from Southeast Asia. So, and there's a lot of reasons for that, I guess, but it's something to think of for the future.
Yes, thank you, Dr. Nayo. Very interesting.
Thank you, Dr. Mihail. So I apologize that we have to move on to the last speaker because of time limitations. So I would like to present the last speaker, Dr. Puspita Anggraini Katili from IMERI University of Indonesia. So she will present in vivo cellular programming by delivery of Yamanaka factors for cardiac regenerations. So I will give the floor to Dr. Puspita.
Thank you very much, Dr. Bramasta and all of the CMARS committee for giving me this opportunity. I hope my talk here will give you a more comprehensive understanding of the cellular reprogramming, especially the in vivo one using the Yamanaka factors for cardiac regeneration. So I will give first the overview of cellular reprogramming, and then we move forward to the role of the iPSC in cardiac regeneration, and then the last one is the in vivo cellular reprogramming for the rejuvenation. So I hope most of you are already familiar with stem cell biology, but if not, let me give you a brief explanation. So the pluripotent stem cells is basically the cells that can give rise to any kind of cells from ectoderm, mesoderm, and then endoderm, except the placenta. And this is the classic cellular reprogramming that you all may know for the Yamanaka factors, OCT4, SOX2, KLF4, and CMYC. So from somatic cells, fibroblasts from the skin, and then reprogram back into the pluripotent stem cells. And actually, in this cellular reprogramming, there are quite many terms that we may need to know. First is reprogramming. For the example is the pluripotency factors. And then the next one is the transdifferentiation. So in example here is from the pancreatic exocrine cells, transdifferentiate into another cell type, the beta cells. And then the last one here, which basically what is the main topic of this talk, is about the dedifferentiation, or we may know as the partial reprogramming. So in here, for example, from adult cardiomyocyte, which is in non-proliferative state, they differentiate back into the immature cardiomyocyte, which has more proliferative capacity for cardiac regeneration. And some of you may already notice this iconic model from Conrad Weddington. So it shows here the cells as the marble. So it's very easy to differentiate normal differential, rolling from the top here into the down side here. This is the normal differentiation. It can be spontaneous. It can be directed in vitro. And for the pluripotencies, for the reprogramming back from the terminally differentiated cell type back into the pluripotent, it's actually going back like taking step by step. from down to the top side. So it's not quite easy. And there is also like a process from differentiated cell type 1 into changing into another type, which is called by direct reprogramming, which is also not as easy as when we differentiate from the pluripotent cells into the terminally differentiated one. So this is, I just explained it briefly about the differentiate between indirect and direct reprogramming. So direct reprogramming, as stated, is actually quite direct. So for example, from already somatic cells, from the fibroblasts in the skin, for example, and then we just direct reprogramming into the cardiomyocyte. So there's no intermediate state, and it's more efficient and reduce the tumorigenic risk. So it's actually suitable for the in vivo, while the indirect reprogramming is the, as you may know, is the process of reprogramming from the fibroblasts derived into the pluripotent stem cells, and then we differentiate into the cardiomyocyte. So there are intermediate state in here, but the positive positive in here is that it can produce in a large scale because the pluripotent stem cells have proliferative capacity. And then the next section, so there is many research involving the cardiac regeneration and repair. So the first one is back in 1998. So the human embryonic stem cell was first isolated and cultured. And then the next milestone is the human iPSC generated back in 2007. And then in here, there is already in mouse, the cardiac fibroblast reprogrammed into the cardiac myocyte in vitro using transcription factor back in 2010. And then we move forward to the human cardiofibroblast reprogrammed into the cardiomyocyte in 2013, and then so on until now. So there's already a history of the direct reprogramming from the fibroblasts into the cardiomyocyte. So as I may mention before, there are several ways into reprogramming the for example, from fibroblasts to cardiomyocytes. So the first one is the classic one that we may all know, full reprogramming using the iPS cells. So from fibroblasts goes to the pluripotent state, and then we differentiate into cardiomyocyte. And then this one, the second one is the partial reprogramming, which I may highlight in the next few slides. So instead of the iPS cells, it goes through the cardiac progenitor cells, which may be found in the adult heart in any individuals. And then the last one is the direct reprogramming that I mentioned before. So from fibroblasts directly into cardiomyocyte, there is no in between, and it is unipotent. So it can only change into cardiomyocyte and not other cells. So basically for the cardiovascular field, especially in the cardiomyocyte research, so when we go upwards, it is actually decreasing the stability. So in the pluripotent, because naturally in vivo, the pluripotent will eventually become a mature cells, the somatic cells. For example, in here, mature cardiomyocyte, and in here, mature cardiac fibroblast. And the cardiac fibroblasts can turn back into the pluripotent cells by using the transcription factors, by using the pluripotency factors, the Yamanaka factors. But as we go down here, it's actually more stable. That's why in the research involving reversing the state back into the pluripotent and then using the pluripotent cells and then use them for therapy. For example, there is a concern about the genetic stability. And this is what we hope to do in the future about the heart regenerative medicine. So the first one is, which is actually ongoing, at least in the mini research in the in vitro stage, and then maybe some in the in vivo. So using the IPS from the fibroblasts, we differentiate into the cardiomyocyte, and then the cardiomyocyte will then be transplanted into the patient. So actually it depends on the disease of the patient. If it has a mutation, then with the cardiomyocyte derived from the IPS can be corrected using CRISPR-Cas9, and then the corrected one will be the transplanted into the patient. And this is the second approach, so using the direct cardiac reprogramming. So using the reprogramming factors, epigenetic factors, and others. So directly from fibroblasts into the cardiomyocyte, and then transduce it and then put it into the patient. And this is the last section of this talk. So why we need to understand about aging, because eventually the therapy, one of the therapy for the patient is because of aging. Aging has many contributing factors in here. During the aging, there are stem cell exhaustion, mitochondrial dysfunction, genomic instability, and other cellular senescence, immune system decline. So how we can make it better for patients in aging, because it has become a problem, especially the population of aging in, for example, in Japan and in other developed countries are more and more increasing compared to the younger ones. And of course, it creates a health problem. And so for the rejuvenation research, so from aging state converts back to younger state. So the ones highlighted in red here means the reversal of the clock aging. So you can see the clock picture here. So it's progressing. There are actually 3 stages here. And then the last one from 2021, there is a rejuvenation event in the embryogenesis, which is discovered by therapists. And so back again with the basic principle of the cellular reprogramming to the rejuvenation state. So the left diagram here depicts the classic one. So from somatic cells, using the cellular reprogramming by Yamanaka factors, converted into the IPS. And then the right diagram here shows what we may need from the old stage of the cells, from the abnormal nuclear envelope, senescence, dysfunction of the mitochondria. Using the cellular reprogramming, it reverts back to the younger state, so becoming normal nuclear envelope and proliferation state and normal mitochondrial function and so on. So doing the reprogramming in vivo actually has some concerns. Why? Because in here, in the in vitro stage, so in vitro is basically what we do in the lab. When we do the full reprogramming, if you notice here, for example, this is the cardiac fibroblasts or fibroblasts from the skin. When we use the Yamanaka factors OSKM, OCT4, SOX2, KLA4, and CMYC, it reverts the cells. So it changed the cellular identity, for example, from a more squamous cells into more round cells. When we do the partial reprogramming, the fibroblasts here, for example, using the Yamanaka factors, it actually still has the same cellular identity, but younger. So the difference is older becoming younger. And in the in vivo, when we do the full reprogramming in the transgenic mice, for example, when we put the Yamanaka factors here, it actually caused concern. So the development of the neoplasm, as you can see in here, so that is one of the biggest risks of doing the full reprogramming in vivo. So with using the partial reprogramming approach, the mouse from older state reverts back to its younger state without the developing possibilities of creating tumor. So why the mouse developed tumor in the full reprogramming? It's because there is just a fine line between the tumorigenesis and the generation when we do it in vivo. So example here, the top line here is the totipotent cells, so it can give rise to any cells, including placenta, and the pluripotent does not include the placenta. So the A here is the process of the direct reprogramming, the transdifferentiation, and then the C here is the classic reprogramming from terminal differentiate cells into pluripotent, and then from the pluripotent differentiate into another cell type. And this is the D here is the one that is the partial reprogramming. So from the terminally differentiated cells goes into the progenitor state. So there are some progenitor cells depending which tissue or organ. And then because of the progenitor state, it's or immature state, it has more proliferative capacity than the terminally differentiated one. So it's has more regenerative capacity. And this B1 here is that when you convert from the terminally differentiated into the either totipotent or the pluripotent, it has the potency of actually when you differentiated them into creating teratoma or tumorigenesis. So what is actually the best condition in doing the in vivo, or the best, what is more easier to do the in vivo lineage reprogramming? So actually it needs to be in a close ontogenic relationship. And then after the injury state, so it's more reactive or activated after the injury or disease. And when the cells is the proliferative, and actually when it's still younger. So it's more when you go from down here to up here, it's more amenable to do the in vivo reprogramming. But of course, the research will need to do how we can do the in vivo reprogramming from the old age and then basically revert to the younger state. So here, this is one of the research showing from the aging phenotypes in the mice. So in the young one, the skin, the stomach, the kidney are all perfect, but in the older version, the epithelium is diminished a bit, and then the stomach as well, the lack of the cells as found in the younger version, and in the kidney, they are increasing interstitial space compared to the younger ones. And by using the Yamanaka factors, it reverts back from the old to the younger self, so back to the younger version. So in relating to the cardiac regeneration, I'm showing you here the recent paper from Chen. So they are using the transgenic mice, and then they induce the back to the neonatal fetal cardiomyocyte by in the transgenic mice, they have a cassette, and then the cassette in the promoter area, they induce the OSKM using the doxycycline. And in here, they show that from previous research mentioning that if you extend the expression over time, so for a chronic period, it's actually induced the formation of the tumors from adult cardiomyocytes. So in here with the alkaline phosphatase staining, the one marked in red here, and then by the NANOC expression, it shows here the formation of the tumor. And this one in the left side basically show the regimen of how they do the doxycycline. And then this is from mesometrium staining. So the blue one is the fibrotic condition, and the dark red one is the health state. So they quantify if it's reduced the fibrotic scars, and it does. So there's significant changes of reduction of the scar size after using the doxycycline induced transgenic mice. And this is the EDU staining, and in here shows what's important here is the increase left ventricular ejection fraction. So compared to the control here, the one with the treatment showed increased left ventricular ejection fraction. So what is the take-home message here is that when you want to do the reprogramming of the cardiomyocyte for the cardiac regeneration, you need to really pay attention into the how much time you need and how much the dosage you need. And then especially since this was done in mice, of course, it will be different when we do it in the larger animals and then eventually in human. So if we only do it in short term, so that is the goal. It is reversible, the differentiation, and then because the immature cardiomyocytes have the more productive capacity, it can regenerate the heart during the myocardial infarction. But if we do it for a quite long term, the differentiation is reversible. So the cardiomyocyte becomes a neonatal but cannot function properly. So it can cause health issues. And then, of course, it's a more continuous extended period, a complete differentiation. It's instead turn it into the iPSC tumor neoplasia. Okay, that's all. Thank you very much.
Thank you, Dr. Puspita, for a really nice presentation. I now open the floor for questions. If not, I can start first. I actually am quite involved with the cardiomyocyte differentiation here also in Copenhagen. So I'm interested to know, I'm not really familiar much with the direct differentiation. How do you feel about with respect to, let's say, when we do, let's say, clinical trials for cardiac regeneration, as of now, we are not sure at what stage of the progenitor, or is it that we need to transplant the mature cardiomyocyte. That's why we are talking more from the perspective of IPS or ES into cardiomyocyte. But when you talk about direct reprogramming, we don't know whether the cells that could be transplanted clinically later are indeed supposed to be direct mature cells. Is there any stage of, let's say, of target cells in the direct reprogramming, or maybe a downside effect of, for example, maybe longer durations of reprogramming compared to IPS, or what is your view? Because with clinical perspective, as of now, we are not sure at what stage.
Yeah. So thank you for the question, Dr. Bramasta. So yeah, it's actually quite interesting question. Because like eventually what we want ideally for the patient is that when we do the cell therapy, and then it can in patient with infarct myopathy, it can actually like proliferate in the in the patient's body, and then so it has the maximum regeneration capacity. But as you have stated before, like we don't know what actually is the condition of the cells that we injected into the patient. So what if it gets out of control, or what if it causes the side effect? So that's why it's still, I think it's still a long journey to make sure that the state of the cells that we need to put into the therapy of the patient. So there are two, as I have mentioned before, there are two approaches. So the first one is we already differentiate the cardiomyocyte into the full, hopefully mature cardiomyocyte, and then we transplanted as many as possible into the heart, into the target. But the problem is because, as you may also know, is the challenge is because when we inject the cells, it may get lost. So actually, the cells that reach the target is not as many as when we inject it. So that is the more on of the problem issue here. And then, but that is quite, in theory, it's quite safe, because when we differentiate the cardiomyocyte, of course, we already tested before in the lab to make sure that the cardiomyocyte is in a normal state without any mutation, without any other abnormalities. So we have controlled it before we inject to the patient. But that is the problem about the delivery. So the cells may get lost. And then the second one is because like we want the heart to regenerate. So the second one is we reprogram into some kind of progenitor or any intermediate cells. So hoping it gives the more regenerative capacity, of course, compared to the mature cardiomyocyte. But again, it is maybe have some risk because we don't know if it's becoming the true mature cardiomyocyte, or it may give rise to the cardiac fibroblasts, for example. Because in the previous presentation I showed is that from the cardiac fibroblasts and the cardiomyocyte is actually close to each other. And when we differentiate the cells in vitro, actually not all of the IPS becoming 100%, right, of the cardiomyocyte, but some of the population are cardiac fibroblasts. So that is also the cause, the challenging issue. So I think we still have quite a lot of work to do, because especially in the cardiomyocyte field, the major issue is because the cardiomyocyte itself hasn't reached the maturation state as the one we found in the native heart tissue. So that is one of the main problem as well. So, but we have from the Chinese paper that there is hope to do the rejuvenation thing. So I think it's a nice step. So we still need to do more steps to do before we can do the therapy in the patients. I think that's my view.
Thank you very much. So I would, because of the time limitation, I would like to thank all the speakers, and I have to end the session number 2. So now I will pass back to the MC for the next session. Thank you very much, everyone.
Thank you very much to all of the speakers for giving us a very insightful and interesting presentation and discussion session. And thank you as well to Dr. Bramasta Nugraha for the wonderful session and moderating our event today. Ladies and gentlemen, we have now arrived to the last session of today's event, which is Symposium 3, Recent Advances in Cardiovascular, Metabolic Technology During Industrial Revolution 4.0 Era. This session will be moderated by our moderator, which is Dr. Anwar Santoso. Before we start, allow me to read Dr. Anwar's CV to the audience beforehand. Dr. Anwar Santoso is from National Cardiovascular Center Harapan Kita Hospital and National Brain Center Hospital, and lecturer at Department Cardiology, Vascular Medicine, Faculty of Medicine, University of Indonesia. His activities consist of being a consultant of cardiovascular prevention and rehabilitation in National Cardiovascular Center, Jakarta, Indonesia, expert team of National Committee of Drug Licensure in BPOM Indonesia, member of National of Development and Research Ethics Committee, and former chairman of Indonesian Teaching Hospital Association and past president of ASEAN Federation of Cardiology. Without further delay, let me pass the spotlight to Dr. Anwar Santoso. The time and place is yours, doctor.
Yeah, do you hear my voice, please?
Yes, doctor.
Okay, thank you very much indeed. Very good afternoon, everybody. So I think I'm delighted that this afternoon I'm going to chair, this very interesting, even though it is the last symposium, but I think it is a very interesting topic, which is the recent advances in cardiovascular metabolic technology in the era of the Society 5.0. And fortunately that we have 3 outstanding speakers available on board already. The first one is Professor Joris Rotmans from Leiden University, Netherlands. And then the other one is Professor Junichi Okada, PhD from University of Tokyo, Japan. And the last but not least, Professor Al-Hadi Bustaman, PhD from Universitas Indonesia. So talking about this, I think, the artificial intelligence 5.0, I think AI has commenced to permeate and rearrange the degenerative disease treatment and prevention and current medical practices. And almost every aspect of human life and technology are being affected by AI. If we look at the data from the United States, that approximately 100 million people cannot preclude from AI penetration nowadays. It has transformed the elemental aspect of human life. Although AI revolution has been underway, the medical world has not been actually able to pursue it. And then, unfortunately, the AI application in the Southeast Asia are still limited. So that's why I think this session is very important in terms of we want to learn a lot from our outstanding speakers this afternoon. And the first speaker, I think, would be Professor Joris Rotmans from PhD from the Division of Nephrology, Department of Internal Medicine, Leiden. And he is a researcher at the Department of Internal Medicine, Leiden University, and Professor of Internal Medicine at Leiden University. Please, Professor Joris, you have about 20 minutes, I think, for your presentation. Please go ahead.
Thank you very much, Dr. Santoso, and good afternoon or good morning to all of you, wherever you are on the globe at the moment. I just want to check if you can hear me loudly.
Yes, we do.
Perfect. Well, today it's a pleasure to me to provide an update on the work that has been done in the last decades on the topic of vascular tissue engineering, with the specific focus on vascular access for hemodialysis, which, as most of you will know, is a treatment for patients with end-stage kidney disease. And these patients need a connection to the bloodstream to use the dialysis machine. And I will give you some background information about various strategies that have been used in the past with the aim to grow tissue engineered blood vessels and provide you an update on the current status of that. And then and actually the work on vascular tissue engineering, at least in my opinion, started, let's say, in 1995. I think there was the moment where a lot of people realized that a lot can be done with tissue engineering, while Dr. Vacanti actually managed to grow a human ear on the back of a mouse. And you could say, well, what's the purpose of that? And of course, it was not really meant to, at that stage, to use this ear for clinical application, but it made people realize that we can do a lot. And it took about 20 years from then when the first application of a tissue engineered ear was being applied in clinical medicine. And since then, a lot of organs and tissues have been generated for tissue engineering purposes, like heart valves, as you know, tracheas, bladders, and also blood vessels. But at the same time, most of these applications are not part of the routine clinical care yet, because a lot of hurdles still needs to be tackled to get it more like a standard treatment. If we specifically focus on the use of blood vessels, of course, the first question engineers need to ask themselves is, well, what's the normal anatomy and function of the tissue or organ that we would like to replace? In this case, a blood vessel, which comprises of multiple different cell types like endothelial cells, smooth muscle cells, and fibroblasts, as well as matrix proteins that all have a different function. And I've listed here a couple of required characteristics of blood vessels that need to be met before a safe clinical application can be pursued. For instance, the burst pressure of blood vessels, of human native blood vessels, is more than 1700 millimeters mercury. So that's massive amount, and that's a big challenge for vascular tissue engineering. At the same time, they should be leak-proof and infection-resistant, and for the specific application of tissue engineered blood vessels as dialysis access, they need to be resistant to repetitive puncture, as that's been done for dialysis access. The first paper in a very nice journal, in this case in Science, about tissue engineered blood vessels was published in 1986. By Weinberg and Bell, who actually used a collagen scaffold depicted here on the left, which they seeded with different cell types present in normal blood vessels, and they did all kinds of mechanical tests to assess the strength. And as you can see on the right, even with the highest concentration of collagen that they can reach, the burst pressure was only 100 millimeters of mercury. So not suitable for clinical or for implantations in vivo. But actually this paper showed that it's doable to make a blood vessel as a starting point, and that was the reason why it was published in Science. The first successful clinical application was done in 2001 by Professor Shinoka, who a vascular thoracic surgeon from Japan, who some of you might know, who now moved to the US about 10 years ago. And he really did major breakthrough work in vascular tissue engineering, primarily for children with congenital heart disease. And actually the first tissue engineered construct was implanted in a 4-year-old girl who had pulmonary atresia, so a not very well developed pulmonary artery. And he created a vascular construct in the lab using cells from the patient herself that were isolated from by doing a skin biopsy. Cells were expanded and seeded on these polymeric scaffolds. And after completion of that seeding and maturation of the blood vessel, it was implanted in the pulmonary artery. And here you see an angiogram of that procedure, where the follow-up at the moment of more than 10 years, even 15 years, or the first patient is now more than 20 years ago, is still functioning very well. Shinoka used a polymeric scaffold, which I won't pronounce, but you can see it on the slide. And initially he used autologous cells from skin biopsies, and later on he switched to CD34 positive bone marrow derived cells to seed the construct. But if we now move to the application of hemodialysis access, it's a different story, right? Because as you might know, more than 3 million patients worldwide depend on chronic hemodialysis, and their access to the bloodstream is really the lifeline for them. Because if they cannot be cannulated, or if there's no access to the bloodstream, dialysis procedure cannot be performed and the patient will not survive. The current access types have very limited success rates. And as you can see on this slide, the preferred type of access is an arteriovenous fistula, where there's a direct connection between an artery and a vein being made by a vascular surgeon, with the aim to create a high flow circuit that is suitable for cannulation. that works well, but the 1-year patency rate of these conducts is about 50%. And so patients need a lot of re-intervention, and I'll show you in a minute more about that. The second option is an arteriovenous graft, where a prosthetic graft is being implanted between an artery and a vein, where the prosthetic graft is being cannulated. And because that's a foreign body, you get some inflammatory response to the prosthetic material, which limits the durability because of stenosis formation in the graft and also in the venous outflow tract in the perianastomotic region. And the third option is a central venous catheter, which is primarily used for patients with acute renal failure, right, where there's no time to do these surgical procedures and to allow these arteriovenous conducts to mature and to make them suitable for cannulation. So there's no doubt there's an urgent need for vascular access innovations in this field. And here you see an overview of the current poor patency of access conducts that we currently use for our patients, where graft and fistulas have about a 1-year patency rate of 50%, as I just mentioned, and these are data from the Netherlands. And tissue engineered blood vessels might provide a solution for that, because you can make them at a tailor-made dimensions, so making the process of maturation, so the growth of the vessel, no longer needed, because they're already of the size that is needed for cannulation. There is no prosthetic material involved, so there's no inflammatory response to prosthetic materials, potentially improving the long-term outcomes. And lastly, there is no pre-existing vascular pathology, which is well known to occur in patients with long-standing chronic kidney disease. The first clinical successful application of tissue engineered blood vessels for dialysis access was done by Nicolas Leroux, who's currently working in Bordeaux in France, but he developed this technology in the United States, in California, and he used actually cell sheets to wrap around a mold, which is here depicted in green on the right side of the picture. So he started with, again, subcutaneous biopsies, where he harvested from all kinds of microvasculature in the subcutaneous fat, endothelial cells, smooth muscle cells, and fibroblasts, and cultured them separately. And you can see that took a couple of weeks for all these cell types. And then he peeled off from the culture flask these sheets of cells, and it's a very delicate process, as you can imagine, and he wrapped it around these molds. And after a couple of months, the mold itself was removed, and then endothelial cells were put on the inside. And that was, these grafts were implanted in 10 hemodialysis patients that needed the vascular access. And it was, as it was called, completely self-assembled. So there was no prosthetic scaffold used to create these blood vessels. And they really look like human blood vessels as well. But the downside is that the processing time took about between 6 and 9 months, which is very, very long, and of course, very expensive as well. Burst pressure of these vessels was very good, more than 3,000 millimeters mercury. But at the same time, the patency at 6 months was only 60%, which was a bit disappointing, right? Because so it's not much better than the current prosthetic grafts. And of course, the processing of these grafts is far more time consuming and more expensive. So that technology was not pursued any further, although the technique itself was very promising. Another example of a technology that is still in clinical trials being done in the US and Europe as well is from Humacyte, and that's a spin-off company from Yale University, where researchers worked for more than 20 years on working on creating these blood vessels. And the technology is different from the previous one. In this case, allogenic cells from a donor bank, vascular cells from a donor bank, are used to seed scaffolds in vitro, so in a bioreactor, as you can see on the right upper panel. And these cells start to produce extracellular matrix proteins to actually build up the structure of the blood vessel. Subsequently, the mold is removed, and these allogenic cells are also being removed from the vascular structure to avoid any immune response, right? Because these cells were allogenic and not from the patient that need the graft. So what's left over is a structure which primarily is being built of extracellular matrix proteins that's subsequently being implanted, in this case as hemodialysis access graft. And the idea is then that subsequently this graft is being recellularized with autologous cells. Here you see an example of a preclinical study in baboons, where indeed there are hardly any cells present at time of implantation, and it's a very collagenous structure, where in 6 months, in this case in a baboon model, you see infiltration of autologous cells in the graft with very promising results, and also spontaneous endothelialization on the inner side of these blood vessels. And these results actually made these researchers starting a clinical trial, and that was published already a couple of years ago in 2016 in The Lancet, where these constructs were implanted in patients in Poland and in the US, in total 60 patients. And here you see the results of that. Again, on the right, you can see that there is a substantial ingrowth of vascular cells, smooth muscle cells, and also endothelial cells, but at the same time, in some regions, also inflammatory cells. But the primary patency at 12 months was, again, a little bit disappointing, with about 33% in the Polish patients and only 13% in the patients from the United States. With the additional interventions to restore and to maintain patency, the secondary patency, so whether or not these grafts will still be usable for dialysis, was quite okay, but a substantial number of interventions was needed to maintain these grafts functional.
Sorry, Prof. Ratman, 2
Yeah.
minutes left, I think, for your presentation.
All right, so I'll speed up then. So we worked on a method to grow in vivo tissue engineered blood vessels, and that you can see here. So we make use actually of these of implants to implant subcutaneously, and we use the tissue capsule that's formed around these implants as a starting point for a blood vessel, because the tissue surrounding these implants is composed of collagen as well. So that was used. I'll speed up a little bit to show you. And we first worked on the modification of these rods to optimize them for this purpose. So we optimized the surface and the content of these rods. We've showed in a rat model that you can grow actually similar types of tissue capsules around these rods, and we selected the optimal composition. I'll skip this one. And then we moved on to a pig model first, where we implanted this rod in the subcutis of a pig, and the tissue capsules that were formed around these rods were implanted as carotid interposition grafts with quite good results. And then we moved on to a goat model of arteriovenous grafting, and this is a video that I would like to show to you in a minute, where you can see here the neck of a goat, where we implant these polymeric rods just subcutaneously. It goes quite easy, and then in this case 4 weeks later, we reopen the location where the rod was being implanted at, and then you can see in a minute that there's a tissue capsule formed around these polymeric rods that we dissect. So we remove the tissue from its location, and we remove the polymeric rods, as you can see here. So that's a very delicate procedure. But on its content and on the luminal side, it really looks like a blood vessel. So here on the right, you see the carotid artery, and on the left, the tissue engineered graft with the rod still in place, and that we anastomose to the artery and to the vein. And then you get a very high flow circuit that is suitable for cannulation, as you can see here. Then here you see some examples of histology, where we show primarily on the right that the number of inflammatory cells declined in time. So at the time of grafting, there were still a lot of inflammatory cells, but after it's been grafted as an arteriovenous graft, this inflammatory response disappeared. And at the same time, there was a strong upregulation of all kinds of markers of smooth muscle cells and fibroblasts. So Desmin expression and myosin heavy chain expression increased in time, and these cells really start to look like a normal blood vessel, at least from a goat. And also these cells were able to contract, showing that indeed there were functional smooth muscle cells in these constructs. And as in the previous studies was also shown, you get spontaneous endothelialization of these grafts. And the patency rate was actually superior to PTFE grafts that we used as a control. So, and currently there's a clinical trial going on to evaluate the efficacy of these tissue engineered blood vessels in dialysis patients. So to conclude, various innovative strategies are currently being developed to engineer new blood vessels. And I think it's pivotal to focus on translational medicine because it's very difficult to get these preclinical studies translated into clinical trials, but strong collaboration with engineers and biologists and clinicians is needed to bring this forward into clinical care. With that, I would like to thank you very much for your attention and thank a lot of people involved in the research that I just showed. And I'm looking forward to your questions.
Thank you very much indeed, Professor Rotmans. So I think what a very interesting, lecture. It is called Where the Machine Meets Biology. So now the next speaker will be Professor Junichi Okada from University of Tokyo, Japan, and he will be talking about the clinical and pharmacological application of multi-scale, multiphasic heart stimulator, UT heart. Please, Professor Okada, you have 20 minutes for your presentation.
Thank you, Chairman. It's my great pleasure to give a talk to you. I'm Junichi Okada at the University of Tokyo and UT Heart Inc. Today, I'd like to talk about clinical and pharmacological application of multi-scale multiphysics heart stimulator, UT heart. We have developed multi-scale multiphysics heart stimulator, which is called UT heart. UT heart can reproduce all fundamental activities of the working heart, including propagation of excitation, contraction, and relaxation, and generation of blood pressure and flow based on the molecular and cellular mechanisms. Now we are aiming to put practical use in clinical medicine. Today, I'd like to talk about patient-specific simulation using UT heart. Especially, I focused on optimization of cardiac desynchronization therapy. What is cardiac desynchronization? What is cardiac desynchrony? Because of the excitation, velocity of excitation propagation in the Purkinje fiber network is very fast. The conduction system supports the synchronization of heart pumping. In the healthy human, heart pumped blood by synchronized muscle contraction. On the other hand, in the case of left bundle branch block, the conduction system blocked around here, and desynchrony is generated in the pumping. In the case of left bundle branch block, QRS and QT width in ECG is prolonged. Ejection fraction and stroke work is decreased, as shown in these figures. Cardiac desynchronization therapy is a device treatment to correct the desynchrony by left ventricular and right ventricular electrical pacing. It is a simple and powerful technique to treat the cardiac desynchrony, like a left bundle branch block. The survival rate of cardiac desynchronization therapy is better than medical therapy, as shown in these figures. Cardiac desynchronization therapy is invasive treatment, expensive device. However, about 30% patient of desynchrony is non-responder. It requires optimizing the stimulation point and timing. To overcome these problems, we created patient-specific heart models for optimizing CRT. This slide shows the outline of patient-specific CRT simulator. At first, we make the patient-specific finite element model of heart and torso based on clinical data. Second, we obtained a reasonable agreement between the simulated and actual blood pressure, electrocardiogram, and echocardiography. At last, we optimized the simulation point and timing of CRT. This is an example. He is a 6-year-old man. He suffers from complete atrioventricular block, heart psychosis, and heart failure. She have already implanted the pacemaker in the right ventricle. We obtained good agreement between the simulated and actual electrocardiogram and ultrasonic cardiography, as shown in these figures. Next, we try to optimize the CRT. The ejection fraction improved about 6% by using CRT in this patient. The simulated ejection fraction shows a good correspondence with the actual ejection fraction in the case of after and before CRT. Black line is the pre-CRT condition, and the red line is the current CRT condition. CRT simulation shows that CRT protocol applied to this case was close to optimal, but further improvement, although little, to be attained. Green condition is better than current CRT, as shown in this figure. Why the ejection fraction is improved significantly in this case? The ventricular aneurysm caused by the thinning of myocardium is corrected by the biventricular pacing. This is a ventricular aneurysm corrected by the CRT. For validation, we are required to prove the statistical superiority in clinical medicine for validation. You have already developed 28 human examples and 50 kidney examples for animal experiment. This slide summarizes the validation of CRT simulation by blind experiment. In the both figures, perpendicular axis is clinically observed improvement in the ejection fraction. On your left, the horizontal axis is simulated improvement in the ejection fraction. On your right, horizontal axis is simulated improvement at maximum dPdt. In this case, we obtain the significant correction, as shown in this figure. The maximum dPdt is the maximum value of time derivative of pressure histories in left ventricle. You have the conclusions. Marit-scale tailor-made heart simulation could reproduce most of the failing heart's pathophysiology and response to CRT, thereby providing mechanics insight into the pathophysiology of heart failure with conduction block. They are collaborators about this work. Next, I'll talk about drug discovery using UT heart. Today, I focus on cardiac safety assessment of drug effect based on combining automated patch clamp and UT heart. Tolsardeplant is serious side effect of drugs, and during the process of drug discovery, every drug have to evaluate the cardiotoxicity. Current guideline for cardiotoxicity testing insists in heart channel assay, APD measurement, and SARA-QT study. These tests have been successful in preventing serious events, but these tests are costly and may not accurately predict the risk, thereby sometimes assigning false positive to possibly useful drug candidate. To overcome these problems, a paradigm shift in cardiac safety assessment is needed. You have developed in silico assessment system for the arithmetic risk of drugs using the three-dimensional hash simulator based on the finite element method. This slide demonstrates our finite element model of heart and torso briefly. Finite element model of torso and heart developed based on the 3D reconstruction of CT image. And principle in the torso model, principal origin represented by the difference of electrical conductivity, and the finite cell model of electrophysiology is embedded in the heart of finite element model. By solving the cell model, which is very complex nonlinear equations, and we can obtain the histories of ionic current and corresponding membrane potential. We employed two kinds of cell models for ventricular cell and Purkinje fiber cell. On your right, this is the sequence of excitation contraction in the control condition without drugs. In the cardiac muscle regime, 22 million cell models are embedded. From the body surface potential map, we can obtain 12-lead ECG. This slide shows a diagram of the assay system. This is a hybrid screening system. The dosing invitation curve of drugs were determined using the automated patch clamp system. Condition of the in silico heart model under specific drug concentration was simulated by modulating the channel parameter in cell models to yield 12-lead ECG. Dosing invitation curve of drugs were determined for 6 ion channels, namely IKR, INA, ICA, IKS, IK1, and ITO. This video shows an experiment. Dosing invitation curve have two parameters, IC50 and H. H represents the slope of the curve. To evaluate the predictability of our simulator, we selected the 12 test drugs from the TDP risk category by red one. On your right, there are dosing invitation curve for 12 drugs tested about 7 ion channels. Green circle corresponding to effective free therapeutic plasma concentrations. In this study, drug concentration quantified by the multiples of the ETCP unbound. You have the result. This is an example of the cardiotoxicity testing using simulator. On the upper figures, there are 2 rhythm bleeds ECG under various drug concentration at heart rate 60 and 40. In the case of verapamil, it is known as a safe drug. As drug concentration was increased, the QT interval prolonged. However, we cannot observe the generation of arrhythmia. On the other hand, in the case of E4031, it is known as a high-risk drug. We can observe the generation of arrhythmia at very low drug concentrations. Simulated 12 ECG during trusted points induced by E031 at 10 times of ETC P unbound are shown in the lower figures. The ECG waveform shows the typical case of torsade points. The torsade points is triggered by the early after repolarization developed in the developed region, as shown in this movie. This slide summarizes the result of in silico risk assessment for 12 drugs tested. Arrhythmia risk quantified by the threshold concentrations relative to ETCP. In the high risk drug in category 1 and 2, their drug shows a very low threshold concentration, threshold values. In the safe drug, in category 4 and 5, we cannot observe the generation of arrhythmia. There are no false positive in this case. This system can predict drug-induced arrhythmogenic risk, reliability, and efficiently. We have the conclusions. We propose the cardiotoxicity testing system combining in vitro channels assay using the automated patch clamp technique and in silico simulations of cardiac electrophysiology. The system can predict drug-induced arrhythmogenic risk, reliability, and efficiently. But this system has some problems. Our simulator have a huge computational cost, and everyone cannot use our simulator. To overcome these problems, we created the exhaustive database of ECG and the various combinations of ion channels in inhibition using supercomputer. This database is freely available at this website. In this website, if you send the ion channel data, it returns a arrhythmogenic risk, ECG, and safety margin promptly without calculations. After that, we've opened this website. Many people used. They are collaborator of this work. At last, I'd like to show the arrhythmia propagation test. The external stimulus was applied to the right ventricular apex under Saprido administration. Saprido is known as the high-risk drug. Premature ventricular concentration absorbs the ventricular fabrication through the torsade points. I did not change the parameter during the calculation, but the excitation propagation is automatically changed to ventricular fibrillation. Under the condition of ventricular fibrillation, heart cannot pump the blood.
Sorry, Prof. Okada, 1 minute left for your presentation.
Thank you for your attention.
Okay, thank you very much indeed, Professor Okada. That's actually very nice presentation. And the discussion, I think, will be carried out at the end of the Symposium 3. And I want to invite Professor Al-Hadi Bustaman from Universitas Indonesia, and we'll be talking about the role of AI to improve the management of diabetes patients. Please, your time, Professor Bustaman.
Okay, thank you. So, is this my presentations can be seen there?
Yes, we do.
Okay. Okay. Thank you for this opportunity. Good afternoon for all of the audience. And today I will present us some of our work related with application of artificial intelligence in the case of diabetic case. So in this presentation, I will introduce a brief about what is data science and AI, and then we will talk about the application of AI in the diabetic screening, something like that. So most of the people now are talking about AI, but because we are coming from mathematical department, so we will introduce that the AI is basically come from the engine of this AI is data science, and part of them is we build the algorithm based on mathematics, statistic, and also a computer science approach. So in AI, basically we must learn how to build the machine learning algorithm, and this machine learning algorithm is the core of the AI and also the data science. So data science is more about how we use the machine learning to perform tasks in the real life problem. So that's the machine can do or doing something like a human. So they have some part of human intelligence in their work. So today we have a lot of data and come from every aspect of our life, including here medical data, like medical scan data, and then all of this now connect to Internet of Things, and then we build a big data. So this need to be analyzed in a good way, or in a good and a good speed as well. So how we analyze this now we introduce more advanced algorithm, like machine learning algorithm in data science. So basically data science is consists of 3 domains, something like this: mathematics, computer science, and domain expertise. So domain expertise is one of the most part that we need to collaborate. For example, in life science and medicine, we will need to collaborate with the doctor or also any expertise in this medicine or life problem. So if we can communicate each other, so we can build data science algorithm, and then we will implement it as a AI application at the end. So what is data science? Basically, this is how we will build the learning algorithm that we can extract knowledge from data. So our focus is how to make the learning algorithm, and AI, how we implement this learning algorithm in machine. So this machine can have the ability to make a decision, reasoning, and cognitive functions like a human. So that is the most interesting about AI. So we have AI, we have data science as its engine. In this area, we have 2 powerful algorithm. We call it machine learning algorithm. Usually we use this for the structured data, but for more complicated data, we use we call it deep learning. So what is the difference between machine learning and deep learning? In machine learning, we still have like human work here, like how to do like feature extraction. But in deep learning, we do all of this activity in machine. Yeah. So now most of the problem we can do both using machine learning and deep learning. But in deep learning, we need more complicated more resource, yeah, for computing power. That is the basic of neural network. We copy how the brain neural network. We make this model and we use this model and then use a computer to compute this model. So we have like here a sensor for input and compute a machine learning algorithm. Then we can have the output as the decision at the end. So that's the most complicated one, mathematical model and mathematical computation here. If we talk about intelligent healthcare now, we are going to reshape our healthcare using intelligent healthcare like this by implementing data science and AI. Yeah. We have many area we can improve, including like disease prevention, treatment, and some of application. Usually we working with like here medical image analysis, genetic and genomic personalized medicine, and we use many wearable device, yeah, to monitor patient and to improve the diagnostic accuracy and efficiency, something like this. So a lot of people can work together here to improve the intelligent healthcare. Basically, in life science, we use many bioinformatics algorithm, and we use a lot of data here and a lot of mathematical and statistical tool to analyze this big data. But the problem now, we are going to have a very massive data, so we need the new methodology to work with this. So why the data science now come using machine learning and deep learning algorithm. And now the data also integrates with the social media and also scientific data. Then we can have many new perspective about how to work with the data. And this also the data is connected each other using Internet of Things and so on. So this is the main part of AI in medicine. We have some data, many type of data, text data, image data, biometric data, and so on. And we have some analysis method, yeah, based on rule-based. This is like classical method, but now most of us are trying to implement machine learning and deep learning. For machine learning, basically we have used this for we use this for supervised learning and unsupervised learning, and also in reinforcement learning. But for deep learning, they have more dimension of data and more complicated. And most of these data are unstructured data. So this is the challenge in medicine. This is the output, classification, prediction, generation, and control. Yeah. Now we're talking about what we are doing in developing AI application in medical image processing. We are now focusing in this research using fundus image. Yeah, we use this fundus image now how to detect some disease inside a human, especially we are working with diabetic, cardiovascular as well, and other disease. Yeah. So in this work, we want to detect some lesion that we can use as a feature to classify the disease. For example, diabetic disease. Our goal in the end, we want to make some machine. We call it the ATMC Sehat, yeah, something that we can use for screening the people using fundus image, something like this. So we can use this machine for screening purpose to assist the doctor in dealing with patient. Regarding diabetes, there are many AI technology have been implemented, like diabetes prediction, lifestyle guidance, insulin injection guidance, blood sugar monitoring, and so on. But we are not focusing in diabetes prediction. These are some area the machine learning and also deep learning has been implementing to build the AI application, especially for diabetic. Yeah. So now we are focusing in diabetic prediction and also the retinopathy assessment, and maybe next we will try to work with more areas like this. In this work, we work with IMERI and also RSCM and also RSUI. In this work, we use combine some clinical, laboratory and image data, and use this for level prediction and advanced prediction. Yeah. And as a result, we can use this for further referral, yeah, or also for treatment recommendation to the doctor. Okay, that is the diabetic can have many problems. Yeah. Now we are focusing in this area, diabetic retinopathy. And also, we are also working with other area like cardiovascular and stroke and so on. But in this presentation, I only focusing on this diabetic retinopathy. Yeah. So this is some of our work with machine learning and computer vision to characterize the diabetic retinopathy using by detecting the lesion in the fundus image. So this is the fundus. Yeah. So there are some feature some lesion here that we can use as a feature yeah, to predict the severity of the diabetic from NPDR into PDR. Yeah, there are some object here that we can use for classification. Yeah. For example, here this is our earlier approach. We use some image processing algorithm combining with the machine learning, yeah, machine learning algorithm to predict the severity of this. Firstly, we want to characterize the lesion, and then after that we predict the severity of the diabetic retinopathy. In this case, we can use many lesion here that we can use to predict the diabetic retinopathy, and we have the accuracy around 80%. Yeah, for SPM around it's around 80. It is also close to 90%. Yeah, it is our previous approach using machine learning, but we then make new learning algorithm using ensemble learning. We combine some deep learning algorithm, then we have more we have better result, or almost more in the average we get 97 F1 score. Yeah, it's close to 100. Yeah, it's very nice. Yeah, very good. After we get the good result, now we improve our algorithm using we call
The Wi-Fi is not working, huh? Sorry, Professor Bustaman, I think the time is already finished, right? So now we are coming to the Q&A session, I think, for the three speakers. So is there any question from the audience? Anyway, I see, one excellent question from Dr. Made Hustrini to Professor Joris. So what do you think, Professor Joris?
Let me see. Thank you. I see the question.
Yes, I read. It is very interesting and promising development of TEBV for alternative to prosthetic grafts. I would like to ask for the excess patency related to thrombogenic complication. As with autologous tissue, it might provide a better profile. It's regarding the patency rate, I think, your works. What do you think?
Yeah, well, that's a very good question, Dr. Hustrini. Thank you for that. The interesting observation is that even prosthetic grafts, they have severe limitations, but not per se primary thrombotic complications. Of course, these grafts can occlude and thrombose, but then most of the time secondary to stenosis. And although the surface is artificial and there's no spontaneous endothelialization of prosthetic grafts, still no occlusions is being observed, primary thrombotic complications. Also in these tissue engineered grafts, we and others have observed that even in the absence of endothelial cells, no thrombosis occur. And that is primarily related to the very high flow values that occur in arteriovenous conducts. It might be different in small caliber vessels, for instance, in coronary bypass grafts, and that's the reason why these vessels have not been used for that application yet. But I hope that's a suitable answer for you.
Okay, thank you, Professor Joris. So I have my question to Professor Okada. What is actually the maximal DPDT can be achieved in your work in terms of the using CRT simulation? What do you think, Professor Okada?
Thank you for your question. Accuracy of DPDT max?
Yeah, sure.
Yeah. But good question. We are about 30 model is calculated, but there are good results to reproduce the DPDT, and it is can predictability of the show the good predictability of cardiac desynchronization therapy, and but the case with cardiac infarction, it was some decreased accuracy, but yeah, you are now trying to these cases to grow
Sorry,
up.
I'm sorry, I got my problem with my internet.
Oh yeah, yeah,
Yeah.
yeah. I think your Wi-Fi is not working very well just now. So thank you, Professor Okada. So I want to be back to Professor Joris. So it is regarding the high shear stress in the normal vasculature actually, which is actually in normal vasculature is better than the low shear stress in terms of the atherogenesis, meaning that the high shear stress, I think, prevents the atherogenesis, but in the low shear stress in the vasculature, I think can induce the atherogenesis. So what do you think in your vascular access? Actually, it is not normal vasculature, Professor Joris.
Yeah, that's really a hot topic because the hemodynamic conditions in arteriovenous conducts are extremely challenging, right? So there's a 40-fold increase in flow profile for instance, in the venous segment compared to the baseline conditions. And there's turbulent flow in an arteriovenous conduct where there are regions of very high shear stress and regions of almost absent laminar shear. And that is one of the explanations why these stenotic lesions occur, primarily in the venous segment, because that part of the arteriovenous conduct is not used to these conditions. And that is actually the direct answer why not all these problems can be solved with tissue engineered blood vessels, right? Because if you implant a completely biological construct in the same configuration, you will have a similar flow profile and similar injury to the vessel wall due to this high flow. And that's why, and I hope to show that in one of the subsequent meetings, we're currently also developing a valve that closes the arteriovenous conduct in between dialysis sessions to prevent the excessive hemodynamic stress to the vein and also the extra demands to the heart, right? Because of the additional cardiac output that needs to be generated. But that is probably for some of the next meetings.
Yeah. Okay, very excellent. Thank you very much. I'm offering one question for the audience. Okay, if there is no question, I think I just want to offer to Professor Bustaman. Your work, I think, is regarding the prediction models in the diabetic patient, I think by screening the retina, right? So how many, I mean, the predictors, how many predictors in your final model can be constructed? And you mentioned that the accuracy of your model is approaching 97%. But you didn't show, actually, I mean, the calibration of your model. What do you think, Professor Bustaman?
Maybe I show my presentation for the last slide. Yeah. Okay.
I think the calibration is, I think, it's very important in models.
Yeah. Okay. This is my last slide. You can see this.
Yes, I see.
Yeah. So in artificial intelligence, yeah, we have some technique, to validate our model. Yeah, we have some technique. Okay, I want to continue my last slide. So after we got our result, now we improve this result with some we call it the graded chem, graded chem technique. So like this, we have some algorithm. So this is our final model here. We get 90% accuracy. That is our improvement. Yeah, we put other deep learning algorithm to focusing what part of this fundus image that can we use as the feature for the classification, so the doctor can easily take this as a note. Yeah. So in artificial intelligence, for validation, we have the methodology. Firstly, we call it we doing like a training process in our model, and based on this training process, we calculate the accuracy, the accuracy of our model based on our training data. And then after we got the accuracy or the performance of our model, we test this model with the we call it testing data, something like the data that we are not used before, and we use some technique on measuring the performance, for example, like using confusion matrix and some. So we calculate how many we got true value or like in our prediction. We also calculate the false value and something like that. So we have some metric. We calculate this metric, then we calculate the performance based on this model.
Okay. Okay. Thank you very much indeed, Professor Bustaman. So anyway, I think although I think this session is very interesting.
Like in accuracy, we have like true positive, true negative, and so on. Accuracy, sensitivity, and so on. So we consider all of the measurement in our model, and we at the end we validate our model with the doctor as well. So
okay, thank you. That's very nice, very excellent works, right? So dear colleagues and dear attendees, that actually we are approaching, unfortunately, I mean the end of the session. And although this session is very, very interesting, and I want to a big applause, I think, for all the three outstanding speakers, Professor Joris Rothman from Utrecht, and Professor Okada from University of Tokyo, and of course, Professor Bustaman from Indonesia. Again, thank you very much indeed for your contribution in the symposium carried out by IMERI. Okay, thank you very much and bye-bye.
Thank you.
Okay, thank you. Have a good time, everyone.
Have a good time. Bye-bye.
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 Arigato gozaimashita.
Terima kasih.
All right.
Thank you very much to Dr. Junichi Okada, Prof. Joris Rothman, and Professor Al-Hadi Bustaman for being the speakers on today's event. And thank you very much as well to Dr. Anwar Santoso for the insightful session towards the end of our event. Ladies and gentlemen, we have now arrived at the end of CMARS 2023, Day 2. We hope every single person and the participants had an amazing experience today, and most importantly, learned plenty from the lectures given today. Don't forget that CMARS 2023 still has 2 more days, which will be just exciting as today. So don't forget to join again tomorrow for Day 3. However, for tonight, CMARS 2023 also has a special event that is a welcome reception, young scientist career session, how to build academic, scientific, and industrial career for young scientists in Indonesia in collaboration with Young International Cellular Senescence Association. The session will start at 7:30 GMT+1 or 19:30 Waktu Indonesia Barat. Be sure to join us again because there will be many amazing guest speakers on the session. We would also like to remind every participant of this webinar regarding the attendance form that you can find in the chat box and in the WhatsApp group. The attendance for that we will also send through email along with the feedback form. Please kindly fill out the form directly afterwards for CMARS can continue to improve and provide satisfaction for every participant. This event will not be successful without our sponsors, Novartis, Novo, Prodia, AstraZeneca, and Media Genomic. Thank you to all sponsors and media partners. As an appreciation to all participants, we would like to invite all of the participants, speakers, and committee to turn on your camera so we can take a group picture together. Please, everyone can turn on their camera. We will wait until at least 2 pages to turn on their cameras. All right, I will count to 3 to take the picture. 1, 2, 3. One more. 1, 2, 3.
Smile.
Thank you very much for joining the group picture. Lastly, we would like to express our gratitude to all participants while also apologizing for any inconveniences during this event. Once again, thank you for your enthusiasm for the symposium and see you on tonight's Young Scientists career session. Thank you very much, and you may now leave the Zoom meeting.